स्टार्ट हो गया क्या? Hello, good evening everyone. My name is Dr. Mohak Kataria. I'm a senior resident working currently in PGI in orthopedics. I did my MBBS in Maulana Azad Medical College. I secured the rank 30 in All India PMT. After that, I did my junior residency in orthopedics in PGI Chandigarh. I secured rank 17 in 2017. Today we are going to discuss about orthopedics. We're going to have a quick revision. Let's start with the history of orthopedics. Um, as we know, the father of orthopedics was Nicholas Andre. He published the book Orthopedic back in the 17th century. Ortho meaning straight and PD meaning child. Basically, it was a memoir for parents to know how to correct deformity of their children. So that was the first account of orthopedics ever made. That's why Nicholas Andre is called the father of orthopedics. When we come to the father of modern orthopedics, father of modern orthopedics is Robert Jones, Jones fracture wala. He was a proponent of radiographs. He was a contemporary of Willem Röntgen, the guy who discovered X-rays. So his propagation was whenever there's an injury or any problem in orthopedics, the first thing you should do is go for radiographs, get some X-rays done to find out what's going wrong. Then we come to the imaging. Radiograph is always used for screening in orthopedics. Uh, there was a question in AIMS in 2018 and before that also in 15 that a child got injury due to glass piece. What should be the first investigation? So it's always X-ray because glass piece contains lead and lead can be seen on X-ray. In the next investigation, we come to CT scan. When do we do a CT scan? C for CT, C for cortex, and C for calcification. So whenever we have to see cortex or calcification, we go for CT scan, computed tomography. Then MRI, M is for MRI and M for marrow. So whenever we have to see marrow, we get an MRI done. For example, occult fractures, there is marrow compression, which is appreciated on MRI. Of course, the soft tissue as well as the cartilage is appreciated on MRI. For metastasis, we go for PET-CT and bone scan. So here's a question on NBE pattern. 11-year-old male complains of painless bony hard swelling arising from right distal femur metaphysis. Swelling was well defined, has well defined margin, uniform consistency, and has a stalk of connection with bone. It grows away from the knee. That's the clue here. The swelling looks smaller on radiograph as compared to palpation on clinical examination. This swelling can undergo malignant transformation, most common of which is chondrosarcoma. This malignant change is best detected by MRI, CT, X-ray, or history and clinical examination. So here in the question itself, it says the malignant transformation will be into chondrosarcoma. We know that chondrosarcoma is a cartilage-based tumor, and cartilage is best seen on MRI. So the answer here should be MRI. This is a case of exostosis, also called osteochondroma, bony stalk with cartilage cap, that is osteo and chondroma, because the lesion is larger to feel as compared to radiograph, which means that the cartilage, it is cartilage covered and the cartilage is not seen on radiographs. Therefore on X-ray the lesion is smaller, but on clinical examination it is larger. Chondrosarcoma is a cartilaginous tumor around the knee and shoulder, occurs in the second to third decade, and it ceases to grow after skeletal maturity. Malignant transformation occurs into a low-grade chondrosarcoma, which is extremely rare. It is a cartilaginous tumor and is best detected on MRI, as I already told you. Cartilage thickness more than 2 cm is diagnostic of chondrosarcoma. CT scan is used for bone, cortex, and calcification, as we have already discussed. MRI is better for soft tissue and marrow. Hence, it is preferred in cartilage, ligament, tendon injuries, as well as in stress fractures, as there is marrow compression. Moving on, now we come to periosteal reaction. Why does periosteal reaction occur? Because the periosteum does not contain regular dense tissue as is seen in tendons and ligaments. So this indicates new bone formation in reaction to some abnormal stimulus. So the connective tissue in the periosteum is not very dense. Therefore, whenever new bone formation will occur, it will breach the periosteum. Whatever stimulus is there which leads to new bone formation can lead to periosteal reaction. So there are three types of periosteal reaction: sunray, quadman triangle, and onion peel. Sunray is seen due to calcification along the Sharpes fibers. It is seen in malignant lesions. It is seen in malignant lesions. Quadman triangle is seen typically in osteosarcoma. However, it can also be seen in other lesions. Onion peel appearance is seen in Ewing sarcoma and osteomyelitis. Onion peel is seen in Ewing's and osteomyelitis. It is also called lamellated appearance. So this is the sunburst appearance. You can see calcification along the fibers, along the Sharpes fibers. This is seen in malignant tumors. Here we can see the radiograph of the same. This is Codman's triangle. This is typically seen in osteosarcoma. This is schematic diagram of onion skin or lamellated appearance. Just like the skin of onion, here is the lamellated appearance, as we can see. So here's the question. So there's a 9-year-old male child who complains of absent movements of the left lower limb. On examination, fever is present, which is high grade. Local temperature is raised. Tenderness is present in metaphysis of lower end femur. Immediate limb is splinted according to the rules of splintage. Intravenous fluids are started. Intravenous analgesics are given. Patient is sent for urgent radiographs. Which of the following is not true about radiograph in such a scenario? Earliest bone change in osteomyelitis is periosteal reaction. Okay. Earliest change of osteomyelitis is loss of soft tissue planes. Acute osteomyelitis periosteal reaction can be solid. Chronic osteomyelitis periosteal reaction is usually sunburst appearance. So this is the wrong statement here. In chronic osteomyelitis, as we have already seen, the periosteal reaction is usually onion skin. Same as in Ewing's. It is not sunburst. Sunburst is seen in malignant tumors like osteosarcoma. Rest all statements are true. As we can see in chronic osteomyelitis, the periosteal reaction is usually onion peel type. Onion peel reaction is also seen in Ewing sarcoma. Sunburst appearance is seen in malignant tumors, usually osteosarcoma, where there is calcification along Sharpes fibers. Codman's triangle is usually seen in osteosarcoma. Now we come to acute osteomyelitis. What is acute osteomyelitis? Osteomyelitis is inflammation of marrow cavity which usually occurs due to infection. Inflammation of marrow. Most common cause is infection. Infection most commonly due to Staphylococcus aureus. This is the most usual culprit in orthopedics, be it any infection, maybe osteomyelitis, maybe septic arthritis. Infection anywhere in orthopedics, we can blame it on Staphylococcus aureus. Radiographical Radiographic changes, the earliest change is the loss of soft tissue planes, which signifies soft tissue swelling. It usually occurs 24 to 48 hours. Within 24 to 48 hours of presentation, there will be loss of soft tissue planes. Uh, there will be no other bony change during this period. Earliest bone change that we can see is periosteal reaction and new bone formation, which occurs usually by second week. During this period, we can get an MRI done, which can tell us about marrow edema. Which can be seen earliest by 24 to 48 hours. Order of investigation in acute osteomyelitis is X-rays followed by MRI and bone scan. Just wait. Hello, I'm really sorry for the interruption. Hello everyone. There was some problem. I was not able to get to the live chat. So, hello Shivraj. Hi Naveen. Hi Ibiza. Hi everyone. So let's continue with it. So the earliest change on MRI, as we have already discussed, it is marrow edema. Marrow edema is the earliest change on MRI. Acute osteomyelitis, metaphysis is the commonest site. Distal femur is most common. Distal femur is the most common site, and spine is common site in adults. Why does acute osteomyelitis occur more in metaphysis? Would anybody like to answer that? Uh, Shivraj, why do you think there is more of acute osteomyelitis in metaphyseal location, not in the diaphysis or epiphysis. Is there any specific reason for that? So let me answer that. In the metaphyseal region, suppose this is the epiphysis, this is the physis. The vessels form a hairpin loop. So here there is sluggish blood flow and stasis of blood is there. So wherever there will be stasis of blood, there will be more chances of infection. Most of the infections in children occur due to hematogenous spread. Hematogenous spread is the most common cause in children for osteomyelitis because in the bloodstream transient bacteremia keeps occurring, and this leads to stasis at the this leads to this, the lodging of bacteria in the areas of slow circulation such as the metaphysis and infection in this region. Most common organism, as we already know, is Staphylococcus aureus. Treatment is antibiotics for 6 weeks, which includes 2 weeks intravenous and rest 4 weeks oral. So here is the vascular anatomy of a child. This is child less than 18 months. This is 18 months to 16 years, and this is adult more than 16 years. So what are we trying to say here? In a child less than 18 months, there is a connection of metaphyseal and epiphyseal vessels. So there's a chance of infection spreading to the epiphysis. If osteomyelitis occurs here, it has a chance of going into the epiphyseal region. Same is there with the adult more than 16 years. The physeal plate, the physeal barrier is gone. The physis is fused and the blood supply is going towards the epiphysis. It is connected. The epiphyseal and metaphyseal blood vessels are connected. So here also there's a chance of the infection going into the epiphysis and finally leading to joint infection. But same is not true in children from 18 months to 16 years of age, because here the physis acts as a barrier for the infection to cross. So the metaphyseal infection stays in the metaphysis and it does not lead to septic arthritis. Let's discuss septic arthritis in some specific scenarios, such as sickle cell anemia. In sickle cell anemia, the most common causative agent is salmonella. Remember that when the question asks about diaphysis, the question is asking specifically about the diaphysis and sickle cell anemia patient, then it is salmonella. Otherwise, most common in even in sickle cell anemia is still Staph aureus. In IV drug abusers, the most common causative agent is Pseudomonas. It is Pseudomonas in IV drug abusers. Pseudomonas causes osteomyelitis. In, in patients with prosthetic walls, For example, question comes, patient had mitral valve replacement, something like that is there, then coagulase negative staphylococcus is the answer, because it grows in prosthetic walls and all the prosthetic materials. Such as staph epidermidis. Subacute osteomyelitis is also known as Brodie's abscess. There's a swelling with a rim of reactive bone formation. So let's summarize acute osteomyelitis. Acute osteomyelitis is inflammation of the marrow occurring due to infection, most commonly Staph aureus, Staphylococcus aureus. The radiological changes, the earliest one is loss of soft tissue plane because of soft tissue swelling, seen in first 24 to 48 hours. Earliest bone change is periosteal reaction and new bone formation, which is seen by second week. Earliest bone change is seen by second week, which is periosteal reaction. MRI can be done to see marrow edema, which usually can be appreciated at 24 to 48 hours. We can also look for the soft tissue around the bone in MRI. Order of investigations is X-rays followed by MRI followed by bone scan. Earliest change on MRI is marrow edema, and it occurs most commonly in metaphysis because of sluggish blood flow and the hairpin bends of the blood vessels. Most common organism is Staphylococcus aureus. Treatment is IV antibiotics for 2 weeks followed by oral antibiotics for 4 weeks. So in sickle cell anemia, the most common organism is still Staph aureus, but if the question says diaphysis, then we have to go for Salmonella. In IV drug abusers, it is Pseudomonas. In prosthetic valve replacement patients, it is coagulase negative staph. Subacute osteomyelitis is also called as Brodie's abscess. There is swelling with rim of reactive bone formation. There will be a radiolucent swelling, and around that there will be radiodense reactive bone formation. So let's now discuss about chronic osteomyelitis. The hallmark of chronic osteomyelitis is sequestrum formation. Sequestrum formation is the hallmark of chronic osteomyelitis. What is sequestrum? It is radiodense avascular bone in the center, which is surrounded by involucrum, which is reactive bone. So in the center there is a radiodense avascular bone and is surrounded by involucrum, which is reactive bone. Cloacae are the draining sinuses in the involucrum. So inside, this is the dead bone with all the infection and the purulent material, and the pus starts to trickle down, come out through various tracts which form in the involucrum. These tracts are known as cloacae. These are sinuses inside the involucrum. So on the inside there is a necrotic avascular bone which is radiodense, which is called sequestrum, which is surrounded by a reactive bone formation which is involucrum, and the sinuses formed inside the involucrum are known as cloacae. Organism, again, it is Staphylococcus aureus, most common organism. And the treatment part of chronic osteomyelitis is surgical. We have to debride it, we have to remove the necrotic bone. So how do we know how much bone should be removed? We have to remove the dead bone. We have to remove till the appearance of live bone, and that can be seen by paprika sign. What is paprika sign? When we do debridement, that is removal of dead tissue, and bone, we have to remove till the appearance of live bone after the removal of dead bone. This is called paprika sign. There will be pinpoint bleeding spots in the bone, that is punctate bleeding. The live bone will bleed. For example, this is the bone surface. It will have punctate bleeding spots. Multiple bleeding spots will be there on live bone. That's how we know that the debridement is adequate. We have to debride till there is punctate bleeding spot, till there is paprika sign. It is very important. So what is paprika? Paprika is basically lal mirch. So when you debride, your bone has to look red. It has to look like the punctate bleeding spots, just like they're in red chili. Then in chronic osteomyelitis, usually there are multiple sinuses and the wound condition is not good. In that condition, we use NPWT, which is negative pressure wound therapy. Negative pressure wound therapy. This is negative pressure wound therapy. It is also known as VAC, vacuum assisted closure. Here it is, vacuum assisted closure, or negative pressure wound therapy. So negative pressure is applied on the wound surface, which leads to upregulation of angiogenesis, and moist environment, which leads to increased healing, and the shearing forces due to the negative pressure lead to the disruption of biofilm. So it is used in after debridement, and vascular endothelial growth factor is released because of the negative pressure. Negative pressure usually kept is -75 to -125 mmHg. So this can be used for wounds for their better healing. So this is the classification of chronic osteomyelitis, Cerny and Mather classification. It is for chronic osteomyelitis. So according to the classification, we have the anatomic type, and then we have the host factor, host or patient factor. So the anatomic type is type 1, which is medullary, that is the infection is inside the medullary cavity. It has not breached the cortex. The cortex is intact. The Type 2 is superficial, that is, the disease is from the outside and it is affecting one cortex, but it is not reaching the cortex, it is only partially affecting it. 3 is localized, which affects the complete cortex as well as the medullary canal, but not circumferentially. And type 4 is diffuse, that is affecting circumferentially all the cortex. All this bone is dead along with the medullary canal. So we can remember it by simple mnemonic MSLD: medullary, superficial, localized, diffuse. Chronic osteomyelitis type 1 to 4 according to increasing severity: medullary, superficial, localized, diffuse, MSLD. Then we come to the patient or host factors. Type A is a normal physiologic host, no comorbidities. Type B is divided into S, L and SL, that is systemic compromise, local compromise, both systemic and local compromise. And type C is treatment morbidity is worse than the present condition, so we should not touch this patient. The surgical treatment of a type C patient would lead to more harm than a benefit. That's why we don't usually operate on these patients. So that's classification of chronic osteomyelitis. Anatomic type 1, 2, 3, 4. That is 1 is medullary, 2 is superficial, 3 is localized and 4 is diffuse. As we have discussed with the mnemonic MSLD. So here is a question. A 4-year-old male complains of fever which is high grade 102 degree Fahrenheit, decreased appetite, inability to bear weight on the right hip. On examination, he has dehydration, tenderness in Carpal's triangle, and swelling in the right hip region with absent movements in the right hip. On radiography, there is mild increase in medial joint space. There is an increase in medial joint space. What is the diagnosis? Septic arthritis, transient synovitis, tubercular arthritis, dislocation hip. So this question is very straightforward. 4-year-old child has high grade fever and decreased appetite. So there's a toxic child. Toxic child means not eating, not sleeping, and he has problem in his right hip. So the diagnosis here is septic arthritis. So here's an algorithm for solving such questions. If the patient is in first 5 years of his life with absent movement at a joint with toxic presentation, then this is septic arthritis. This is definitely septic arthritis. If there is a decreased range of motion in the hip and there is flexion, abduction and external rotation, Faber, flexion, abduction and external rotation, then if the child is non-toxic, usually 6 to 12 years, it is a transient synovitis and it can be treated with rest. But if the child is toxic, there is raised ESR, CRP, raised TLC as well as fever, then the diagnosis is septic arthritis, which needs urgent arthrotomy and lavage. Lavage matlab wash. Arthrotomy, opening of joint. So we surgically open the joint and wash it thoroughly. That is the treatment for septic arthritis. And then we give antibiotics for 6 weeks. Same, 2 weeks IV and 4 weeks oral. So septic arthritis is actually a misnomer. It is not an arthritis. Septic arthritis is impending arthritis. If we do not intervene surgically, it will lead to arthritis. It is an orthopedic emergency. It needs urgent debridement. Why? Because in septic arthritis, the most common organism is Staph aureus, and it has something called proteolytic enzymes in it, which can lead to cartilage destruction. Therefore, it needs urgent debridement. So, if septic arthritis patient is not debrided urgently, it can lead to arthritis and ankylosis of the joint and other septic sequelae, joint destruction basically. Now we come to CRMO. This is a chronic recurrent multifocal osteomyelitis. It is an aseptic form of osteomyelitis and primarily affects children and adolescents. It is aseptic, it is not an infection. Blood cultures and biopsy do not yield any microbial growth, and there is no response to antibiotics because there is no organism. It is an autoimmune disease and has been autoimmune hypothesis has been postulated, and it is associated with inflammatory bowel disease. So that finishes our osteomyelitis. Now we are moving on to tuberculosis. Tuberculosis is most common disease in India. Pulmonary tuberculosis is the most common. In orthopedics, spine is the most common site for tuberculosis. Spine, mostly dorso-lumbar spine, followed by dorsal, followed by lumbar. That is the order. And the disease is usually paradiscal. That is, if this is the vertebra above, this is the disc, this is the vertebra below. The disease involves the disc, the upper half, the lower half of the upper vertebra, and the upper half of the lower vertebra. This is a paradiscal disease. That's how tuberculosis affects the spine, the paradiscal manner. Evaluation on X-rays, we can see a loss of curvature. Loss of curvature occurs due to muscle spasm. For example, the normal dorsal spine, it has a slight bit of kyphosis. That might be straightened out, or the lumbar spine, which has a lordosis, that becomes straight. That is the loss of curvature occurs due to muscle spasm. This is the change seen on X-ray. We do a contrast enhanced MRI to evaluate for TB spine, and the gold standard is CT guided biopsy. CT guided biopsy we do and see caseating granulomas. That is a sure shot sign that there is TB. So this is the gold standard. After this we can start treatment. This is also called tissue diagnosis. For treatment, we follow the middle path regime. Middle path regime we follow for treatment of TB in spine. What is middle path regime? Middle path regime is that we start all the patients on anti-tubercular drugs and we evaluate. We operate only when there is worsening of deficit or no improvement after ATT. That is the middle path regime that is used in spine TB. Then we come to POTS paraplegia. The two types of POTS paraplegia: early onset, which occurs within 2 years of the disease, and late onset, which occurs after 2 years. The grading of paraplegia is done based on the motor function of the patient. So grade 1 is that the patient is unaware of the deficit. Patient doesn't know he has any weakness, but when we examine the patient, we can see the patient has clonus or maybe Babinski, maybe ankle clonus, basically human signs. So that is grade 1. The patient is unaware of the deficit, but clonus is present. Grade 2, we can appreciate clumsiness, but the patient is somehow able to walk. Till the patient is able to walk, it is grade 2. Then in grade 3, there is paraplegia in extension, and less than 50% of sensory loss is there. So if we look at the spine in the lateral view, these are the vertebrae. Here is the spinal cord. This is an interior disease. It is affecting vertebral bodies. So whenever compressive symptoms will occur, they will first occur on the anterior part of the cord. The compressive symptoms will first occur on the anterior part of the cords, of the spinal cord. So the interior sensory tracts will get affected first, and the posterior ones will get affected later. So that's why less than 50% sensory loss means that coarse touch, and pain are affected first. That is the interior. There is less than 50%, and proprioception, vibration, and fine touch are still intact. Then it is grade 3. But in grade 4, the posterior columns are affected, and proprioception, vibration, and fine touch are also gone. So that is more than 50% of sensory loss. That's it. The grading is based on motor function. Grade 1, patient unaware of deficit, clonus present. Grade 2, there is clumsiness and somehow the patient manages to walk. Grade 3, there is less than 50% sensory loss. In grade 4, there is more than 50% sensory loss. So now we are going to discuss about the TB of hip joint. TB of hip joint Acetabulum is the most commonly affected site. Acetabulum is the most commonly affected site. In the femur, Babcock's triangle is the most commonly affected site. Patient most commonly presents with a painful limp. Patient comes with a painful limp, plus minus a history of weight loss, fever, and X-ray feature is juxta-articular osteopenia or osteoporosis. It is very commonly asked. Juxta-articular osteopenia is the X-ray feature of hip TB. Then we have stages of TB hip. TB hip stages. Stage 1 is synovitis, that is inflammation. So whenever there will be inflammation and collection inside the joint, the joint will tend to go into a position where the joint has maximum volume. So that is flexion, abduction, and external rotation, Faber. So the joint will go into Faber, that will be the attitude, flexion, abduction, external rotation, seen in stage 1 of synovitis. Very important question. With apparent lengthening, again very important, it is not a true lengthening, apparent lengthening occurs. This is also important question, asked multiple times. Then there is stage 2, which is early arthritis. Early arthritis, there will be flexion, adduction, and internal rotation of the limb, and shortening will be there, which will be usually less than 1 centimeter. In late arthritis, the same attitude with more than 1 centimeter shortening is there. Then there is stage 4, when there is subluxation or dislocation. You just have to remember these terms, might be asked sometimes. Wandering acetabulum or motor pestle type. These are all kinds of presentations of TB hip. All can be seen in different kinds of patients. And stage 5 is sequelae. So sequelae or advanced arthritis. So stage 1 is synovitis with Faber and apparent lengthening. Rest stages have Fadir and shortening. Type 4 is dislocation or subluxation, and type 5 is advanced arthritis. Then we have another classification of TB hip. You don't need to remember this. Just look at these words. This might be asked sometimes. Traveling or wandering acetabulum. It has been asked. Wandering acetabulum is seen in which disease? It is TB hip. Then there can be a dislocating type. There can be a type similar to Perthes. There can be protrusion, protusoacetobuli type, atrophic, motor and pestle type. All these types can be seen in TB hip depending on the patient presentation. Treatment of TB hip depends on the stage. In stages 1 and 2, that is synovitis stage 1 and early arthritis stage 2. In these we give ATT along with traction if that is required, and then we might need to do joint debridement or synovectomy, and the patient might heal with this only. For example, there was a collection, we drained it and did a synovectomy of the synovitis. After that, if the patient, the joint was still in early arthritis, that is stage 2, we can still salvage the joint. So this is the treatment. But from stages 3 onwards, the joint is not salvageable, so we give anti-tubercular treatment, followed later by either a joint replacement or joint excision or a joint fusion. Any of these can be done depending on the patient. If there is still an active infection, we need to go for excision, in which case we do excision arthroplasty or girdle stone arthroplasty. In girdle stone, what we do is, suppose this is the neck of femur, this is the head, this is the acetabulum. In girdle stone, we cut the head and neck from here and remove it. So this is done in chronic infective conditions of the hip. For example, we are not able to control the infection. If you're not able to control the infection and we need a mobile joint, we go for excision arthroplasty. If the infection gets controlled maybe 1 or 2 years after the treatment, then we can go for joint replacement, total hip arthroplasty. That can be done. So here are a few questions based on NEET. First radiologic sign for active tubercular arthritis: localized osteoporosis, sclerosis, joint space reduction, osteophytes. So as we already discussed, the initial sign of active tubercular infection is localized osteoporosis or juxta-articular osteopenia, as we just discussed. Apparent lengthening is seen in which stage of TB hip? Apparent lengthening. As we discussed, stage 1 has apparent lengthening. Stage 2, 3 have shortening. Stage 4 is dislocation or subluxation. Stage 5 is advanced arthritis. So this question has been asked. Apparent lengthening is seen in stage 1. Girdle stone arthroplasty is carried out for chronic elbow infection, chronic hip infection, acute elbow infection, acute hip infection. So it is chronic hip infection, as we just discussed. This is girdle stone arthroplasty, where the head and neck is removed. It is done in chronic infections of the hip joint. So femoral head and neck removed. This is girdle stone arthroplasty. TB sicca involves which joint? Hip, shoulder, elbow, or knee? So the answer here is shoulder. Sicca means dry. So we see that in TB of shoulder, there is no or minimal collection. So it is called TB Sicca. Then we come to TB of the knee joint TB. The initial focus is in the synovium. Most common cause of monoarticular arthritis in children is TB. Most common cause of monoarticular arthritis in children is TB. So classically we see triple deformity in TB. It can also be seen in rheumatoid arthritis. Triple deformity of knee, which is posterior subluxation, external rotation and flexion. Posterior subluxation, external rotation and flexion. Treatment is arthrodesis or replacement depending on whether there is any active infection. If active infection is there, then we have to go for arthrodesis. If the infection is controlled, then we can go for replacement. So triple deformity, posterior subluxation, external rotation and flexion of knee joint is seen in TB and rheumatoid arthritis. So bony ankylosis, that is bony fusion at the joint, is seen in septic arthritis. Septic arthritis we see bony ankylosis. Why? We have already discussed in septic arthritis there are virulent bacteria just like Staphylococcus aureus, which lead to secretion of proteolytic enzymes which destroy the cartilage. Cartilage destruction occurs because of the proteolytic enzymes which exposes the subchondral bone, the bone underneath the cartilage, and this leads to bone-to-bone union or ankylosis. So bony ankylosis is seen in septic arthritis because of the action of proteolytic enzymes on the cartilage, leading to destruction and subchondral bone getting exposed, which leads to bone-to-bone union or bony ankylosis. Fibrous ankylosis is seen in TB, but TB in spine leads to bony ankylosis. Why is that now? Because in spine the weight of the body, that is the vector of the weight of the body, is perpendicular to the joint surface, so it leads to better compressive forces and bony ankylosis. While in hip the weight was leading to little bit of shear forces and a bit of compression at the hip joint, so the forces were not that much to create a bony ankylosis in TB hip. But in TB spine, the ankylosis occurs because of greater compression. So now we are done with the bone infections. We can quickly revise the bone infections. So first we discussed about acute osteomyelitis, which occurs in metaphysis of long bones, and we give IV antibiotics for 2 weeks, followed by 4 weeks oral. Then we had chronic osteomyelitis, in which the treatment is always surgical. It needs sequestrum removal, also known as sequestrectomy. Both these are most commonly caused by Staphylococcus aureus. Then we discussed about septic arthritis and TB. Septic arthritis seen in toxic child, not eating, not sleeping. Treatment is urgent surgery to prevent joint destruction in arthritis, followed by IV antibiotics, same as acute osteomyelitis. TB we have discussed, most common site is spine. We follow the middle path regime, and in hip joint there is we give traction and ATT, followed by debridement if stage 1 or 2, and replacement for stage 3 to 5. And in knee joint there is typically triple deformity, which is posterior subluxation, external rotation, and flexion. So that's it about the musculoskeletal infections. Now we will move on to bone tumors. Bone tumors, most common is metastasis. Most common bone tumor is metastasis. Most common primary malignant bone tumor is multiple myeloma. Most common primary malignant bone tumor is multiple myeloma, but it involves the marrow, the hematopoietic tissue, so second most common primary malignant tumor of bone is osteosarcoma. It is also the most common non-hematologic, not non-hematopoietic tumor. It is osteosarcoma. Then as we know, benign tumors are well defined and they have a narrow zone of activity, and malignant tumors are relatively ill defined with a wide zone of activity. Usually the malignant tumors do not respect anatomic barriers, and they also have a wide zone of transition. So this is different from the wide zone of activity. The wide zone of transition means that we are not easily able to differentiate between the normal and the abnormal tissue. For example, if this is a distal femur, for example, and here we have a benign tumor, it is well defined, and there is narrow zone of transition, like this is the abnormal tissue inside and this is the normal tissue. But in case of a malignant tumor, that differentiation is not easy, it is hazy. We're not able to tell where the tumor ends and where the normal bone starts. So that is wide zone of transition seen in malignant tumors. So bone tumors, most common is metastasis. Most common primary malignant bone tumor is multiple myeloma. And second most common primary malignant bone tumor is osteosarcoma. So we come to differential diagnosis. Infection. We can easily confuse osteomyelitis with Ewing sarcoma since both have onion skin periosteal reaction, and Ewing sarcoma can present with fever and raised ESR. So sometimes it becomes difficult to differentiate between osteomyelitis and Ewing's on the radiology. That's why we need histopathologic examination. That's why there's a dictum which says culture every biopsy and vice versa. So if you are suspecting infection and you want to get the cultures done, that is culture and sensitivity, you should also send the sample for biopsy, that is histopathologic evaluation, because they can present with similar presentations and there could be a diagnostic dilemma. Another differential diagnosis is myositis ossificans. So the mnemonic is myositis ossificans, mature outside. It sometimes mimics a type of osteosarcoma, but osteosarcoma is mature on the inside. Mature means calcification. Calcification. In myositis ossificans, the periphery will be more calcified than the center. Suppose this is the lesion, so periphery will be more calcified. Similarly, in osteosarcoma, the center will be more calcified because center is the dead and necrotic tissue. So dystrophic calcification occurs more in the necrotic central tissue. That's why in osteosarcoma, the calcification will be more towards the center, and in myositis ossificans, it will be more towards the periphery. So that is mature outsides. Age is an important factor in determining the tumor. For example, the tumor of first decade is Ewing's. It is metadiaphyseal. It is not purely diaphyseal, it is metadiaphyseal. It arises from the metaphysis and goes to the diaphysis. So it is a metadiaphyseal tumor. Second decade tumor is osteosarcoma, which is purely metaphyseal. GCT occurs usually after skeletal maturity, normally 20 to 40 years of age, and it is epimetaphyseal. It grows very close to the joint, but it does not breach the joint. It goes very close to the joint, does not breach it. So intraarticular spread is not there. Chondroblastoma occurs before skeletal maturity and it is purely epiphyseal. Occurs before skeletal maturity and it is purely epiphyseal. So now we will discuss the radiographic appearance of the various lesions. Radiographic appearance of the lesions. So it can be geographic as in well defined. This is a geographic lesion, well defined lesion usually seen in benign tumors. This is the increasing order of malignant potential. So geographic lesion will be less malignant. Moth-eaten type multiple lytic lesions means more towards malignant potential, and permeative is the most aggressive, most malignant of the tumors. So moth-eaten appearance is like some punch hole type, something have been eaten out. Multiple lytic lesions are there. Permeative lesion is like this, very ill defined and with wide zone of activity, just like we can see here. So this is an example of a geographic lesion, as we can see on the radiograph. This is most probably a benign tumor, as it is well defined and it respects the anatomic barriers such as the cortex. So this is example of a geographic lesion seen in benign lesions. This is a moth-eaten appearance. As we can see, there are multiple lytic lesions. This could be a malignant lesion. And this is a permeative diffuse lesion with a wide zone of activity. Most probably this should be a malignant tumor. So now we will discuss about the benign tumors. So they're classified according to the characteristics, that is bone forming tumor, cartilage lesion, fibrous lesion and cystic lesions. So there is bone forming benign tumors. Most important is osteoid osteoma. It occurs most commonly in femur diaphysis. So typically there's a young male complains of night pains, young male who complains of night pains, and the pain is relieved by non-steroidal anti-inflammatory drugs. This is your most important clue in the question. The pain gets relieved by non-steroidal anti-inflammatory drugs. So this is an osteoid osteoma. The hallmark of osteoid osteoma is that the cortical nidus is less than 1.5 centimeter, which is seen on CT, and it is more than 1.5 centimeter in osteoblastoma. The only difference is in the size of the cortical nidus. Otherwise, on histopathology, both are same. Both osteoid osteoma and osteoblastoma are same on histopathologic examination. The only difference is in the size of the cortical nidus as well as the location. Osteoblastoma mostly occurs in posterior spinal elements. And there is no malignant transformation. So the treatment we need to do is for the pain. If the pain gets relieved by NSAIDs, it's fine. Otherwise we have to go for radio frequency ablation. Sorry. Radio frequency ablation. Or we can go for open surgery. Both can be done. So young male, femur diaphysis, night pain relieved with NSAIDs, and there's a cortical nidus which is less than 1.5 centimeter. It's osteoid osteoma. So here is the cortical nidus, as we can see. Next we come to benign cartilage lesions. Benign cartilage lesions. Chondroma. It is a hyaline cartilage lesion. Mostly it is seen in phalanges of hand. Phalanges of hand. Hyaline cartilage lesion. This is the image of chondroma and chondroma. Lytic lesion, usually hyaline cartilage, usually seen in metacarpals and phalanges. Phalanges is the most common. And, there are certain syndromes associated with it, like Olier's disease, multiple end chondromas, Maffucci disease, which is associated with hemangiomas of the overlying soft tissue. So, multiple end chondromas with hemangiomas of the overlying soft tissue. Usually, end chondromas are benign, but those associated with these syndromes, Olier's and Maffucci, have malignant potential. Both of them have malignant potential. Next, we discuss osteochondroma, which is also called exostosis. As we have previously discussed, it occurs more around the knee and the proximal humerus before closure of physis. And it grows away from the joint. It has a large cartilage cap. So it will be small on X-ray and big on clinical examination. Then let's discuss about fibrous lesions. Fibrous lesions. Most common is fibrous dysplasia. In fibrous dysplasia, there is replacement of normal marrow by fibrous tissue. Replacement of normal marrow by fibrous tissue. McCune-Albright syndrome. In McCune-Albright syndrome, there is polyostotic fibrous dysplasia, cutaneous pigmentation, which is also cafe-au-lait-McCules, and endocrine abnormalities such as precocious puberty. So there's a triad. Of polyostotic fibrous dysplasia, cafe-au-lait-McCules, and endocrine abnormality, mostly precocious puberty. It is seen in McCune-Albright syndrome. McCune-Albright syndrome. There's another syndrome associated with polyostotic fibrous dysplasias, which is called Maza-Brod syndrome, and it also has intramuscular myxomas. So polyostotic fibrous dysplasia with intramuscular myxomas is Maza-Brod syndrome. Polyostotic fibrous dysplasia with intramuscular myxomas. Basically, there's a missense mutation of GS alpha, which leads to the replacement of normal marrow by fibrous tissue. On X-rays, we can see Shepherd-Crook appearance and ground glass appearance. Ground glass appearance is because of the fibrous tissue instead of the marrow, which leads to the appearance of ground glass. This is the shepherd's crook appearance. So this occurred due to multiple fractures and healing, leading to change in the shape of the proximal femur, just like the shepherd's crook. So this is typical of fibrous dysplasia. This is known as shepherd's crook appearance, seen in fibrous dysplasia. Then we have non-ossifying fibroma, another of the benign fibrous lesions. Benign fibrous lesion. Non-ossifying fibroma. This is a well-defined lobulated eccentric lesion in the metaphysis. Well-defined lobulated and eccentric lesion in the metaphysis. The importance is that it is a giant cell variant, and the treatment is observation. We usually don't have to do anything with it, we just have to observe. So there were two fibrous lesions, fibrous dysplasia associated with McCune-Albright syndrome and Maza-Brod syndrome, and there is shepherd crook appearance and ground glass appearance. And there is another one, non-ossifying fibroma, which is well defined and lobulated inside the metaphysis, and it is eccentrically located, and it is a giant cell variant. Then we come to the cystic lesions of the bone. Cystic lesions of the bone. So this is unicameral bone cyst, also known as simple bone cyst. Simple bone cyst. Here we can see the physis. So it is seen in children, skeletally immature. And this is in the metaphyseal location. Here we can appreciate a single cyst cavity. This is a single cavity, and here we can appreciate fallen fragment sign. This is the fallen fragment sign. So simple or unicameral bone cyst is mostly seen in upper end of humerus, as we just saw, and there's a fallen fragment sign. The cyst is usually central. Simple cysts are central in location, and commonest lesion of childhood, commonest lesion in children is simple or unicameral bone cyst. It occurs due to focal defect in metaphyseal remodeling. So metaphyseal remodeling does not occur, which leads to cyst formation. And since this is a single cavity, so if the cortex from somewhere falls inside, it will fall to the bottom. That signifies that this is a single swelling, the single cyst, single cavity. So this is known as fallen fragment sign. It goes to the bottom of the cavity. Treatment is curettage, or we can do steroid and sclerosant injection. Sclerosant like polidocanol, it leads to endothelial damage of the cavity. Endothelial damage of the lining occurs, which leads to coagulation cascade activation. here is fibrosis and obliteration of the cavity. Obliteration of the cyst cavity occurs because of fibrosis due to activation of coagulation cascade. That's how sclerosant injection helps in simple bone cyst. Polidocanol is used as a sclerosant in simple bone cyst. It is also used in varicose veins, polidocanol. Steroid injection can be done to prevent recurrence, and curettage is the surgical treatment. Curettage is basically scraping off the walls of the cavity. We scrape off the walls of the cavity and remove all the cells from the cavity. So basically jhadu lagana, that is curettage. So all the contents are scraped off from the cavity. So that is it for simple bone cyst. Single cavity, central location, proximal humerus, metaphysis, skeletally immature. And treatment is sclerosant injection or curettage. Then we come to aneurysmal bone cyst. Aneurysmal bone cyst. It occurs in proximal humerus more commonly than it occurs around the knee joint. It is blood filled. It is eccentric in the metaphysis. Compared to simple bone cyst, it is eccentric, not in the center. And treatment here is extended curettage. झाड़ू नहीं लगाना, अभी पोचा लगाना है. So extended curettage, that is, we curate the walls, we scrape off the walls, and then we put some adjuvant to prevent recurrence. Some adjuvant to prevent recurrence, like phenol, liquid nitrogen, argon beam laser. These are few adjuvants which we use in extended curettage. Phenol, liquid nitrogen, and argon beam laser. That is, so here we can see a multiloculated cystic cavity in the metaphysis. This is usually eccentric in a location. We're not able to appreciate it here. It's almost in the center. So this is an image of aneurysmal bone cyst. So what is the difference between a simple bone cyst and an aneurysmal bone cyst? Simple bone cyst is single, central. Aneurysmal bone cyst is eccentric. Simple bone cyst occurs due to focal defects in metaphyseal remodeling, and aneurysmal bone cyst is blood filled due to venous stasis and eccentric in location. Treatment is curettage versus extended curettage. So those are the difference between a simple and an aneurysmal bone cyst. Then we move on to vascular tumors. Vascular tumors, most commonly it is hemangioma, affects the vertebral body. On X-rays, if this is the vertebra, we see patterns like this. This is jailhouse appearance seen on X-ray, jailhouse appearance. If we take a axial section, if we cut it like this and take a section, then we'll be able to see the same thing end on like this. So this is polka dot appearance. This can be seen on axial section of CT. The lesions are bright on both T1 and T2. The lesions are bright on both T1 and T2. That's it for hemangiomas. So this is the polka dot appearance on your left. And this is the jailhouse pattern. On X-rays. Then we discuss some non-neoplastic lesions. For example, Paget disease. This occurs in 5th to 8th decade. Most common site is vertebral body, pelvis, and proximal femur. It is a disorder of osteoclasts. So there is increased lysis of bone due to increased activity of osteoclast, which is seen in the early lytic phase. In the late sclerotic phase, there is compensatory osteoblast activation, which leads to formation of a sclerosed thickened bone with coarse trabeculae. On histopathology, we see woven irregular bone which is not aligned according to the stress lines. Treatment is bisphosphonates to inhibit osteoclast activity, NSAIDs for pain, and calcitonin. So it is seen in 5th to 8th decade, most commonly in the vertebral body and pelvis, maybe in the proximal femur. Early lytic and late sclerotic phase are seen. Then we move on to benign aggressive tumors. So these are benign, but they can have metastasis in some cases. That's why they are called benign aggressive tumors. So number one is giant cell tumor. Giant cell tumor, it is seen in 20 to 40 years of age, and distal femur is the most common location. Remember, for all tumors, rapidly growing areas are the commonest site. So what are the rapidly growing areas in a skeleton? These are around knee, and shoulder. So most of the tumors occur in these locations around knee, that is distal femur and proximal tibia, and shoulder. So goda और moda यहीं पे होंगे most of the tumors. So distal femur is the most common site for GCT, but the distal and radius is more specific for GCT. Like if an X-ray is shown with a lytic lesion in distal radius, you should think about GCT as your first differential. So pulmonary metastasis is seen in 3% of the cases of GCT. Although it is a benign tumor, still there is pulmonary metastasis in 3% cases, and malignant transformation can occur in up to 5% cases. So there is multinuclear stromal cells, which are the tumor cells. Multinuclear stromal cells are the tumor cells. Sorry, mononuclear stromal cells are the tumor cells, and the multinucleate giant cells are there. So on histopathology, we see multinucleate giant cells in a sea of mononuclear cells. So the stromal cells, the mononuclear stromal cells, are actually the tumor cells. And on X-rays, we see that it is an eccentric expansile epiphyseal lesion, which is purely lytic. So it goes very close to the joint, but it does not breach the joint. It is an epiphyseal lesion, eccentric expansile epiphyseal lesion, which is purely lytic, goes very close to the joint but does not breach it. So what is the hallmark of histopathology? There is multinuclear giant cells in the sea of mononuclear cells, but then we talk about giant cell variants. So they also have giant cells. So how do we differentiate between giant cell variants and giant cell tumor? So this is the thing. The nuclei of the stromal cells are identical to the giant cell nuclei in GCT. This is a hallmark of GCT, that the nuclei of all the cells will be identical. Identical nuclei will be there. This is not seen in giant cell variants. So hallmark of GCT is that we have to look at the nuclei of both the cells. So here is an image of a lytic lesion, eccentric, expansile. Expansile means it is thinning out the cortex. Eccentric, it's more towards the lateral side. Lytic, this is the osteolytic appearance. This is uh, more radiolucent, and it is going very close to the joint, going almost to the subchondral region, but it is not breaching the joint. So this is GCT of distal radius, GCT of distal radius. Same here, as we can appreciate on the lateral view, it is very close to the joint. The cortex here is thinned out, so it's expansile, and it is a lytic lesion in the epiphysis. It is eccentric, more towards lateral than medial. So this is a GCT. So all the E's come in here: eccentric, expansile, epiphyseal. Then we discuss about chondroblastoma. This is another benign aggressive tumor. So it occurs in the epiphysis of proximal humerus, and as we can see, the physeal line is still there, so it occurs before skeletal maturity. So it is a well circumscribed epiphyseal lesion, and there are chicken wire calcifications. Here we can see chicken wire calcifications. Treatment is extended curettage, that is curettage plus some adjuvant. Another benign aggressive lesion is a chondromyxoid fibroma. Chondromyxoid fibroma. It is seen in proximal tibia, young male, and it is a well circumscribed lesion. As we can see here, it is a geographic appearance, well circumscribed lesion, and treatment here is also curettage. Then we have giant cell variants. These are the tumors which also have giant cells on histopathology examination. They are variants of GCT. These are aneurysmal bone cyst, brown tumor, chondroblastoma, chondromyxoid fibroma, non-ossifying fibroma, simple bone cyst, simple bone cyst, or unicameral bone cyst, and Langerhans cell histiocytosis. Langerhans cell histiocytosis. So you can remember by some mnemonic if you can try. I tried ABC but couldn't form the rest of it. So you can think about something. So A for aneurysmal bone cyst, B for brown tumor, C for chondroblastoma and chondromyxoid fibroma. And by cyst, we can remember if ABC is there, then simple cyst is also there. So from fibrous lesions, chondromyxoid fibroma, and another fibroma is non-ossifying fibroma. So you can remember something like this. Then we come to malignant tumors. Most commonly seen is osteosarcoma, most commonly asked also. It is the second most common primary malignant bone tumor. It is also the most common non-hematopoietic primary malignant bone tumor. The hallmark here is production of osteoid. Since it is osteosarcoma, so it is producing bone. The malignant cells are producing osteoid bone basically. Malignant cells are producing bone. It is a tumor of second decade, occurs in most commonly in the second decade, and it mostly occurs at the sites of most rapid bone growth. As I told you previously, most rapid bone growth areas are around the knee, that is distal femur, proximal tibia, and proximal humerus metaphysis. Proximal humerus metaphysis. So these are the three locations where osteosarcoma most commonly occurs, and it is more commonly seen in hereditary form of retinoblastoma and Lee-Fermani syndrome, that is P53 mutation. Lee-Fermani syndrome and retinoblastoma can have osteosarcoma. Treatment is neoadjuvant chemotherapy, that is chemotherapy before surgery. We give neoadjuvant chemotherapy, then we do either a limb salvage surgery or an amputation. It depends on the spread of tumor. Depends on the spread. Followed by adjuvant chemotherapy. This tumor is radioresistant. All primary bone tumors are radioresistant except Ewing's. Ewing's responds to radiotherapy. We give radiotherapy in Ewing's. All others are radioresistant. Most common metastasis is to lungs. Osteosarcoma most commonly metastasizes to lungs, and stage is more important than grade. Grade is histopathology grade. Since it is a malignant tumor, all osteosarcomas will be high grade. So grade is of no use to us. For detecting the prognosis, we need to see the stage, we need to see the spread of tumor, and according to that we will decide on the treatment. So stage is a more important prognostic factor in osteosarcoma than grade, because all osteosarcomas will be high grade. So that's it. Osteosarcoma, production of bone by malignant cells. It is seen in second decade at the sites of most rapid bone growth, that is around the knee and shoulder, goda or moda. More common in patients with hereditary form of retinoblastoma and Lee-Fermani syndrome. And treatment is chemotherapy followed by surgery followed by chemotherapy again. Metastasis to lungs is common. So this is osteosarcoma. As we can see, here is a typical periosteal reaction, sun ray type of appearance, sun ray or sunburst appearance. There is calcification along the Sharp's fibers. Along the end of the reaction, we can see here, we can appreciate a Cordman triangle as well. As you can see here, this is a Cordman triangle and this is Sharp's fiber calcification, that is sunburst appearance. Same can be seen on the lateral view as well. Now we come to Ewing sarcoma. Ewing sarcoma can present like osteomyelitis. It is a tumor of the first decade. There's a destructive lesion in the metadiaphysis of long bone. That is, for example, this is the epiphysis, this area is the metaphysis, and here is the diaphysis. So it will arise from the metaphysis and grow into the diaphysis. So it is a metadiaphysis tumor. Not a diaphyseal tumor, it is a metadiaphyseal tumor. It starts from metaphysis only, and it has onion skin periosteal reaction. We've already discussed about that. That is lamellated appearance or onion skin appearance. So ossification is there in multiple rows. So that is onion skin periosteal reaction, and the origin is from marrow cells. Ewing sarcoma origin is from marrow cells. So here are a few markers. It is a MYC2 positive, that is CD99, also known as MYC2. This tumor is positive, and translocation 1122 is the most common translocation. This one we need to remember, translocation 1122 and MYC2. So these two are the markers of Ewing sarcoma, and there are some poor prognostic markers which are chemoresistance, relapse, and distant metastasis. Distant metastasis is the most important marker of prognosis. If distant metastasis is there, it is a worst prognostic marker. Rest relapsing disease and chemoresistance are there. And Ewing sarcoma, we give chemotherapy A, B, C, D. So we can remember as A, B, C, D, E. E for Ewing's. In Ewing's we give A, B, C, D. So A for actinomycin, B for bleomycin, C for cyclophosphamide, and D for doxorubicin. A for adriamycin, A for actinomycin, B for bleomycin, C for cyclophosphamide, and D for doxorubicin. Ewing's is both radio and chemosensitive, so radiation therapy is also done in Ewing's tumor. It is radio and chemosensitive tumor. So here we can appreciate the lamellated pattern or onion peel. Here it is better demonstrated. Onion peel appearance or lamellated periosteal reaction. It is seen in Ewing sarcoma and osteomyelitis. Ewing sarcoma and osteomyelitis have these features. So now we come to solving tumor questions. How to solve tumor questions? So there will always be some clues in the question through which you can solve these questions. So site is the most important clue. Where the tumor is, whether they are telling about epiphysis, maybe metaphysis, diaphysis, where exactly it is, and which bone. That can be the most important clue in the question. For example, if they say distal and radius lytic lesion, think of GCT. Always think of GCT. If they say proximal humerus epiphysis, think of chondroblastoma. Similarly, if they're talking about proximal humerus metaphysis, lytic lesion or cystic lesion, then we can think of simple bone cyst or unicameral bone cyst. Then age is another important factor for diagnosis. As we know, some tumors occur in the first decade, some in the second, some occur after skeletal maturity. So we have to think and answer accordingly. So most important clue is the site and then is the age. After that, type of periosteal reaction and some other X-ray features will be there, or maybe histopathology feature will be there to guide you in the diagnosis. Then there is chordoma. Chordoma arises from remnants of the notochord. It is seen in sacrum and base of skull. Sacrum and base of skull. Histopathologically, there are falciferous cells. These are cells with vacuolated cytoplasm. Vacuolated cytoplasm. Treatment is wide resection. Chordoma arises from remnants of notochord. Therefore, it is seen in sacrum and base of skull. Adamantinoma. Adamantinoma is seen in tibial diaphysis followed by mandible. You can remember it like if someone is too adamant about something, we first kick them on their shin and then we punch them in their face. So tibia followed by mandible. Adamant people. Kick them on the shin, punch them on the face. When it occurs in mandible, it is called as ameloblastoma. Ameloblastoma. Treatment is wide resection. Then metastasis, which is the most common tumor. Metastasis occurs in 5th to 8th decade. It is mostly affecting the axial skeleton and the proximal parts of appendicular skeleton. Mostly dorsal spine is affected. This occurs because of the Bateson plexus. The Bateson plexus, we know, is a plexus of veins in the axial skeleton. It connects breast, kidney, thyroid, lungs, and prostate. All of them drain into the Bateson plexus, and through this plexus, through this venous drainage, the metastasis occurs. So these are the common organs from where metastasis occurs: breast, kidney, thyroid, lungs, and prostate. So as we know, breast and prostate, breast is most common for metastasis in females, prostate is most common for metastasis in males. It's obvious. And both of them have blastic mets, osteoblastic mets. That is, they form bone, they form more bone wherever they go. And renal and thyroid mets are lytic. They lead to osteolysis. So the risk of fracture is increased. Risk of fracture is increased. In case of lungs, mixed lesions are seen. Both lytic and blastic lesions can be seen in case of lung metastasis. And the important thing about lung metastasis is that it goes distal to the knee and elbow. So if there's a lesion distal to the knee and elbow, and it's an unknown primary, we should think of lung mets first. So in breast and prostate, there are blastic mets. In kidney and thyroid, there are lytic mets, and in lungs, they are mixed. So here's a question. This image goes in favor of what malignancy? This image, we can see this triangle. This is Compartment triangle. So out of these options, Ewing sarcoma, osteosarcoma, multiple myeloma, chondrosarcoma. So our best option would be osteosarcoma. Although Compartment triangle can occur in any malignant tumor, it can occur in any malignant tumor, but if we have to choose one out of these, it is osteosarcoma. So Here's the explanation. This looks like the lower end of femur and the I'm sorry, and the physis is just closing. Physis is just closing. As we can see, it is closing. It's still there a little bit. It's about to close. So probably the person is in second decade. So we're talking about a metaphyseal tumor, second decade, and lower end of femur. Epiphyseal fusion at lower end of femur occurs at 18 years. So this is second decade, and as we can see, Quadment triangle. So the most common is osteosarcoma. Ewings can also have Quadment triangles. Subperiosteal abscess can also have it, but since it is a second decade X-ray, best answer would be osteosarcoma. Ewing's tumor periosteal reaction usually is onion skin type, just as in osteomyelitis. Multiple myeloma occurs usually in 6th to 7th decade. Lytic punched out lesions in the axial skeleton. There are lytic punched out lesions in the axial skeleton in multiple myeloma. So that cannot be the answer. And it occurs in 6th to 7th decade. So the lesion does not have a calcified or radiodense mass, which is hallmark of cartilaginous lesions such as chondrosarcoma, as we see chicken wire calcifications, and punctate calcifications are seen in cartilaginous tumors such as chondrosarcoma. Calcification. So chondrosarcoma can be ruled out in this case. The lesion has metaphyseal location with Codman's triangle. So it's most likely osteosarcoma, but definitely we need histopathology examination for confirmation of the diagnosis. It can be any malignant tumor. Bone tumors, as we have already discussed, most common is metastasis, and most common primary malignant bone tumor is multiple myeloma, followed by osteosarcoma, followed by Ewing's. Multiple myeloma, osteosarcoma, and Ewing's. Most common primary non-hematopoietic malignancy is osteosarcoma, as we've already discussed. Multiple myeloma involves the hematopoietic tissue. And age-wise, if we are talking about first decade, most commonly it is Ewing's and unicameral bone cyst. In the second decade, it's osteosarcoma and aneurysmal bone cyst. So clinical picture should be kept in mind before you decide on the answer. Think of the clinical picture first, then answer. So this is the same picture, mostly skeletally immature single cavity with the fallen fragment sign. So this is unicameral bone cyst. This is a simple unicameral bone cyst. It is usually seen at proximal humerus, as we have already discussed. On X-ray, it is centrally located and purely lytic lesion with a well-defined outline. The transverse diameter of the cyst close to the epiphysis is as wide as the epiphysis. Fallen leaf or fallen fragment sign is pathognomic manifestation, as we have already discussed. It represents that the fractured bone settles to the most dependent portion of the cyst. Hence, it means that the cyst is unicompartmental, that is, it is a simple cyst. It doesn't have any septae, it is unicompartmental. Treatment we have discussed, it is steroid and sclerosing injection, or maybe curettage plus minus bone grafting to fill the gap. So differentials, we have aneurysmal bone cyst, which is eccentric expansile. We have discussed E's, E for eccentric, E for expansile, metaphyseal lesion, and it elevates the periosteum. Usually in the lower limb, that is proximal tibia, and treatment we have discussed, E for extended curettage. So we do extended curettage with some adjuvant. In GCT, there is eccentric expansile epiphyseal lesion. So this was metaphyseal, this is epiphyseal. Eccentric expansile epiphyseal lesion. which abuts the subchondral bone, and treatment is again extended curettage or excision. Fibrous cortical defect is well-defined lobulated eccentric lesion in the metaphysis. We usually do not operate or do anything to it. We just observe. Fibrous cortical defect, we only do observation. Mirel's criteria is developed for the evaluation of risk of fatigue fracture, severity of osteoporosis, risk of pathological fracture, severity of neurological deficit. So the answer here is risk of pathological fracture. Mirel's criteria is used for evaluating lytic lesions and predicting whether fracture will occur in it or not. That is, do we need to fix it prophylactically or not? That's decided by Mirel's criteria. So the risk of pathological fracture is decided by Mirel's criteria. There's a scoring system which is based on the presence or absence of pain, the size of the location, the size of the lesion, the location of the lesion, and the radiographic appearance of the lesion to quantify the risk of impending fracture. In malignant lesions, originally it was described only for metastatic lesions. So, patients with maximum risk of pathological fracture are having lytic peritrochanteric lesion involving more than 2/3 the diameter with severe pain. So, patients with score 7 or less are observed, and patients with score 8 or more are operated and prophylactic internal fixation is done if the score is 8 or more. So here is the criteria: site, pain, lesion characteristic on X-ray, and the size of lesion. So we add up the score. If it is greater than equal to 7, then no fixation is done. If it is 8 or more, then prophylactic fixation is done to prevent the fracture in the lesion. So that's it about bone tumors. If you guys have any doubts, please let me know in the chat section. We can discuss them one by one. If you have any questions, you can please come up with them. So let us start with trauma. In trauma, whenever there is a fracture, what is a fracture? Fracture is a breach in the continuity of the cortex. For example, this is the bone, there's a breach, it is called fracture. Simple. Fracture in the is the breach in the continuity of the cortex. So how do we diagnose a fracture? Simply there are two ways. One is radiologic, another is clinical. Radiologic, we just get an X-ray done, a radiograph done. This is usually the first investigation we do in orthopedics. Radiograph. Whenever there is some problem, we get an X-ray done. So there we can simply see the breach in continuity of the cortex, and hence we can diagnose the fracture. It's no rocket science. In clinically, we have something called pathognomic sign. Pathognomic or surest sign, that is abnormal mobility. Abnormal mobility. What does abnormal mobility mean? It means movement is occurring at some point other than the joint. For example, your upper limb, it moves at the shoulder joint, it moves at the elbow joint. For example, it's moving somewhere here. It means there's a fracture in the humerus. Simple. So if there is some abnormal mobility other than the joint, it means there is a fracture. This is the pathognomic sign. That means अगर ये है तो fracture पक्का है. If abnormal mobility is there is definitely a fracture somewhere. If this is not given in the question, for example, they ask pathognomic sign or the surest sign, then you can go for the next best thing, which is crepitus. But what is crepitus? If this is the fracture end, and when we move it, it will lead to the feeling of crepitus. वो जो रगड़ सुनाई feel होती है, that is crepitus. But this should not be done. If the patient has fracture, he'll be in a lot of pain, and eliciting crepitus is not ethically correct, and we should not be doing it because it will cause significant pain to the patient. So it is not done. So it should only be marked when abnormal mobility is not there in the answers. Another most consistent sign for fracture is tenderness. But it is non-specific. Tenderness can occur without fracture also. That's why the pathognomic sign is abnormal mobility. So here it is. Tenderness is the commonest sign of fracture. It is commonest sign, but tenderness can occur without fracture also. So it is not specific. Abnormal mobility is the surest or the pathognomic sign of fracture. Then we have few facts like rate of mineralization. For rate of mineralization of bone, we do tetracycline labeling. Tetracycline labeling, it gets lodged inside the bone, and the rate of deposition of tetracycline into bone will be equivalent to the rate of mineralization. So that's how we can assess it. First primary center of ossification appears at the end of second month of intrauterine life. Marker of bone formation is serum osteocalcin. Serum osteocalcin is a marker of bone formation. Marker of bone resorption is urinary hydroxyproline and TRAP. That is serum tartrate resistant acid phosphatase. It is released from osteoclast. Hydroxyproline is the degradation product of collagen. Collagen degradation. Hence, urinary excretion of hydroxyproline is a marker of bone resorption. So the types of fractures, first is trauma, that is due to significant trauma the fracture occurred. Another is insignificant trauma. In this there are stress fractures and pathological fractures. So we'll discuss about the types of fractures first due to significant trauma. So these are the various types of fractures according to the fracture pattern. This is transverse fracture. By definition, it is less than 30-degree angulation is a transverse fracture. It occurs due to direct trauma to this site. Direct trauma leads to transverse fracture. Oblique fracture is when the angulation is more than 30-degree. This angle here is more than 30-degree. It is an oblique fracture. It occurs due to compression. It occurs due to compression, axial loading. Then there is spiral fracture. Spiral fracture is a low energy fracture. It occurs due to twisting forces. Then there is comminuted fracture. It occurs due to high energy trauma. Multiple small pieces of bones are there. That is a comminuted fracture. Another high energy trauma fracture is segmental fracture that breaks at two places. This will be segmental fracture, that is it broke at two different places. Another type is avulsion fracture, that is occurs due to avulsion of some tendon along with a chip of bone. So this is avulsion fracture. So these are the types of fractures. uh, you could just remember the names, that will be enough. Then we come to fractures without significant trauma. There are two kinds, a pathological fracture and a stress fracture. Pathological fractures is abnormal bone, that is due to some pathology the bone is weakened. So the bone is weakened because of some pathology. This leads to, when there is normal load bearing on a weakened bone, it leads to fracture. That is a pathological fracture. And whereas in stress fracture the bone is normal and the load is abnormal. For example, repetitive loading. That is abnormal loading. For example, in dancers, marathon runners, military recruits, interns. So they can have stress fractures. So that's the difference. So pathological fracture, most common cause is metastasis. Mostly it occurs in proximal femur, maybe neck of femur fracture, maybe pertrochanteric. And previously we used to say that the most common cause of pathological fracture is osteoporosis because it is much more commoner than metastasis, much more common. But then we realized that osteoporosis occurs in everybody, so it is a physiological condition. So it should not be called pathological fracture. So new term was designed for it, which is called fragility fracture. Fragility fractures are seen in old osteoporotic bones because it is a physiological condition and not pathological. It is seen in vertebrae and distal radius, like Colles fracture. Seen in old age, it is mostly a fragility fracture. So in pathological fractures, the hallmark is that the pain was present even before the fracture occurred. So the patient presents to you with pain. And as usual, being an orthopedician, you get an X-ray done without asking anything. So on the X-ray, you see there's a lytic lesion. Then you will have to decide whether to fix this or not. Then we have to decide whether to fix the fracture or not. So here we apply Mirel's criteria. We apply Mirel's criteria for the prediction of pathological fracture, whether prophylactic fixation is needed or not. So we'll apply the Mirel's criteria and see whether we need to fix the fracture pathological fracture prophylactically or not. Then we come to stress fracture. Stress fractures are actually fatigue fractures. They're fatigue fractures. The bone is normal bone with increased cyclic loading. For example, in army people, it is commonly seen. In dancers, just before the event their when their practice is in full flow, that time they can have stress fracture. So army वालों में जैसे 26 January, 15th August parade, before that they have March fracture because of increased intensity of their march or whatever. So the key complaint is point tenderness. Point tenderness is there. Patient will pinpoint that this is the point where I am having pain, and the pain increases after activity and it is relieved by rest. Pain increases after activity and is relieved by rest. This is typical of a stress fracture. Site is mostly lower limb. Of course, lower limbs are bearing the weight. It is common sense that stress fracture will occur in the lower limbs, and distal tibia is the most common site. Distal tibia is the most common site. In foot, second metatarsal is more common than third metatarsal. This is called march fracture. Second metatarsal and third metatarsal, it is seen in army personnel because they do march past, and the second metatarsal shaft as well as neck can get fractured. So both, second is more common than the third. It is a clinical diagnosis. Most of the times, the patient presents with a history of maybe some repetitive motion or some repetitive activity, maybe a marathon runner, maybe a dancer, maybe army personnel, maybe some sports person, and comes with a point tenderness and pain which increases with activity. And so the diagnosis is clinical because X-ray usually does not pick it up for 2 to 3 weeks. It is when it is in the form of an occult fracture. We will need an MRI to pick up the occult fracture. And so if we have any doubt in clinical diagnosis, we can go for an MRI to confirm the diagnosis of an occult or a stress fracture. If multiple stress fractures are there, then we go for a bone scan. Multiple stress fractures can be detected with a bone scan, because if different parts of the body are having occult fractures, you can't get MRI done for all the parts. You can't get so many MRIs done, that will be very expensive. So then we go for bone scan. So multiple stress fractures, investigation of choice is bone scan. So let's discuss about Jones fracture. Father of modern orthopedics का fracture है, named after Robert Jones. So what exactly is a Jones fracture? It's a fifth metatarsal base fracture that we all know, but that is divided into three parts. These are the three parts: 1, 2, and 3. 1 is the part proximal to the metaphysis, epiphyseal region. 2 is the metaphyseal region. 3 is the diaphyseal or the shaft region. So Jones fracture is the fracture of zone 2. It is the metaphyseal region fracture. So where exactly does the fracture occur? Here it is, the fracture line passing like this. So the area which is articulating with the fourth metatarsal, that is intermetatarsal articulation. This is the intermetatarsal articulation. इस रीजन में जो फ्रैक्चर होगा, that will be Jones fracture. That will be Jones fracture. The area proximal to this part 1, this is a pseudo Jones fracture. It is an avulsion fracture of peroneus brevis tendon. Peroneus brevis is attached at the tip, so it is an avulsion fracture of the peroneus brevis. And the zone 3, which are the shaft fractures, they usually occur because of stress. Here stress fractures can occur in zone 3. So what is the importance of Jones fracture? Why is it named after the father of modern orthopedics? The reason is the blood supply to this region. Some of it comes from this side, some of it comes from this side. So this region is watershed. This region is watershed of blood supply. The blood supply is precarious here, hence it has a propensity of going into non-union. That's why this is important. Watershed area of vascularity and higher chances of non-union in zone 2 fractures, which are Jones fracture. That's why this is important. Then we come to open fractures. So what is an open fracture? What is an open fracture? Whenever, suppose this is the bone and there was a breach in it, the fracture occurred, the bone broke, so there will be hematoma formation. Hematoma formation, which is also called as fracture hematoma. This hematoma is called fracture hematoma. When this hematoma communicates with the environment, when fracture hematoma communicates with the environment, it is an open fracture. It is an open fracture. So basically it has two components, fracture and wound. Wound, that is soft tissue defect. So soft tissue is more important. It needs to be addressed first. After that, we care about the fracture. First, the wound should heal, then we care about the fracture. So classification, as we all know, modified Gustello-Anderson classification of open fractures. This has been taught since childhood, I mean MBBS days. So there's a grade 1 fracture, which is a clean wound, and the skin wound is less than 1 centimeter. Uh, these dimensions are usually arbitrary, uh, but the thing is, there's a simple fracture pattern, clean wound, and usually less than 1 centimeter. Mostly it is an inside out injury. You understand, inside out injury, that the wound occurred because the bone pierced out, not because of the outside forces. So it's an inside out injury. Usually it is a grade 1 fracture. Usually after thorough wash we consider it as a closed fracture. We treat it accordingly. We treat it like a closed fracture. Usually grade 1 Gustello-Anderson type is treated as closed fracture. Grade 2, there is soft tissue damage which is not too extensive, and the size of the wound is more than 1 centimeter, and there's a simple fracture pattern. There are no flaps, no avulsions, so there's no extensive soft tissue damage. There is no periosteal uh, stripping. Then we come to grade 3. These are open comminuted fractures. They're comminuted fractures. If the fracture is comminuted, then the size of the wound does not matter. It is already grade 3 if it is a comminuted fracture. Or there's a simple fracture with extensive soft tissue injury and periosteal stripping. It is more than 10 centimeters usually. There's a simple fracture with a big wound and periosteal stripping. Then we have grade 3. Grade 3 is further divided into 3. Grade 3A, B and C. Grade 3A has adequate soft tissue coverage despite the high energy injury. So we don't need soft tissue coverage procedures. We have adequate soft tissue coverage of the fracture despite the injury. That is a 3A. Then 3B is inadequate soft tissue coverage. So we need some soft tissue coverage procedure, maybe some plastic intervention, maybe split skin grafting, or maybe some flaps. And grade 3C is vascular injury which requires repair. Grade 3C is the vascular injury which requires repair. So that is Gustello-Anderson classification, very important from exam point of view. Then how do we manage open fractures? So as we've already discussed, there are two things to it. One is the wound, other is the fracture. So we first have to take care of the wound. It is very important to take care of the wound. Only after that we can take care of the fracture. So for the wound, immediately we start antibiotics, then we go for surgery, that is debridement, that is removal of infected and necrotic material, and lavage. Lavage is wash. We give a thorough wash to clean the wound, and then depending on the debridement and the final condition after debridement, if we are satisfied with the wound condition, if we think it is clean enough, then we go for primary closure. If we don't think it's clean, we go for a delayed primary closure, in which we keep the wound open, we dress it up, and then go for a re-look debridement, usually after 48 hours. So we can go for delayed primary closure if we are not satisfied with the wound condition. And at the same time, in the primary surgery, when we do the debridement, we also do fracture stabilization, which is done in the form of external fixator. Which is done in the form of external fixator. Since the wound is infected, it's an open fracture, we can't go for internal fixation, we can't go for plating because that will lead to infection. We can't go for casting because that will lead to wound problems. That's why we go for external fixation in open fractures, so that once the wound heals, we can plan for definitive fixation. Once wound heals, we go for definitive fixation. So the wound is more important. Even some textbooks describe open fracture as a soft tissue injury with a fracture, just to emphasize how important this soft tissue injury or the wound is. That's how it is defined: soft tissue injury with a fracture. That is an open fracture. Wound healing is the primary aim. So we start broad spectrum empirical antibiotics initially. We don't know the causative agent, and we go for debridement and lavage. Then depending on the adequacy of debridement, maybe primary closure, maybe a delayed primary with a relook debridement after 48 hours. It all depends on when the patient presented. The wound condition will all depend on when the patient presented. We always treat open fractures as an emergency. We have to operate them as soon as possible. So if the patient comes within 6 hours, which is called the golden period, then we can try for primary closure, because then there are less chances of infection. If the patient comes after 6 hours, usually we go for relook debridement. Usually we go for relook debridement. Now we talk about the growth of long bones. All the long bones, with an exception of clavicle, develop from a cartilaginous model. Cartilaginous primordia, that is enchondral ossification. That is, there's a cartilage model. For example, this is the bone. So primary ossification center forms here. This is the cartilage model, which then leads to formation of ossification and formation of bone. So primary center of ossification, primary ossification center is seen in the center of the diaphysis, and secondary ossification centers are formed at the ends, at the epiphysis, which are usually seen at or after birth. This is enchondral ossification or endochondral ossification. The primary ossification centers are seen in the middle of shaft. They begin by the end of second month of intrauterine life. And secondary ossification centers appear at the ends of the bones, and they're mostly seen around and after birth. Around and after birth, the secondary ossification centers develop. So endochondral ossification, when bone formation occurs in pre-existing cartilage model. That is, the bone replaces the cartilage model. Bone replaces the cartilage model. Cartilage is not getting converted to bone. The bone is replacing the cartilage model in endochondral ossification. So first there is a cartilage model, then ossification occurs in it. It is seen in all long bones except clavicle. It is seen in vertebrae, pelvis, and bones of the base of skull. The base of skull has enchondral ossification. Intramembranous ossification, in this the mesenchymal cells differentiate into osteoblasts and directly form bone. There is no cartilage model in it. It is seen in skull vault, maxilla, mandible, and clavicle. So basically the skull vault, the facial bones, maxilla and mandible, and only long bone, that is clavicle. This is very important to remember. Clavicle is the only long bone which is lying horizontal and which has intramembranous ossification. So this is the milking position. Milking position. That is the position while milking a cow. So this we have created to remember the ossification, when ossification occurs. So the joints towards the sky, that is the shoulder, the wrist, and the knee, they ossify at 18 years of age. They ossify at 18 years of age, whereas the joints away from the sky, that is the elbow, the hip, and the ankle, they ossify earlier. They ossify at 16 years. Another way of remembering is, once we become adults, once we become 18 years of age, we are, जैसे बोलते हैं, अपने पैरों पे खड़ा हो गया. पैरों पे खड़े होने के लिए क्या चाहिए? नी. सेकंड थिंग, अपने कंधों पे पूरा भार उठा लिया, that is shoulder. These two things you can remember. कंधों पे भार उठा लिया और पैरों पे खड़ा हो गया. पैरों पे खड़ा हो गया might confuse with ankle, but that's how I remember it. I don't know. Maybe it's just a bad mnemonic. That's fine. I think this picture is good enough to remember. Then we come to the cells of the bone. So there are three cells: osteoblast, osteoclast, and osteocyte. So osteoblast, they are the bone forming cells. Osteoblasts are the bone forming cells. They're rich in alkaline phosphatase, which is a marker for increased bone turnover or increased activity. Osteoblasts form the bone, and they have surface receptors for 1,25-dihydroxyvitamin D3 and PTH. These are two important surface receptors seen on osteoblast: 1,25-dihydroxy D3 and PTH. Then we come to osteocytes. Osteocytes are 90% of the cells in the mature skeleton, and they are basically, they get converted from osteoblasts. The osteoblast, when they become senescent, they become osteocytes, and they are important for extracellular calcium and phosphate concentration control. So they fine tune the resorption of calcium and phosphate according to the extracellular concentration, and they regulate it, the osteocytes. the majority of the bone in mature skeleton. Then we come to osteoclasts. Osteoclasts are multinucleate giant cells. They are formed by fusion of multiple mononuclear cells. So these cells are of mononuclear lineage. Mononuclear lineage. Characteristic is infolding of plasma membrane. Infolding of plasma membrane, which is also called ruffled border. So osteoclasts are seen in resorption pits. They're called house-shaped lacunae in cancellous bones and cutting cones in cortical bones. So this is the pit, and here osteoclast is there with its ruffled border. So this is the ruffled border. This is the ruffled border, which is the site for bone resorption. This is the pit. This is the sealing area. Integrins seal this area and adhere tightly. So the cell is tightly adhered to the sealing area, and this ruffled membrane secretes various enzymes such as TRAP and carbonic anhydrase, which leads to bone resorption. So with organic matrix resorption, osteoclasts are left in shallow excavations, which are house-shaped lacunae in cancellous bone and cutting cone in cortical bones. So it leads to bone resorption. Now we come to fracture healing stages. So first stage is hematoma formation and inflammation. Hematoma formation and inflammation after the fracture. The inflammation peaks at 48 hours. First of all, there is hematoma. Then there is inflammation, which peaks at 2 days or 48 hours. Then the repair starts. The primary callus response is there. Primary callus forms at 2 to 3 weeks. This is a fibrous callus. Then this primary soft callus, which is a fibrous callus, then end condyle ossification occurs, which leads to formation of the hard callus, which takes 2 to 3 months. The hard callus takes 2 to 3 months. So you can remember it as 2 to 3 days, 2 to 3 weeks, and 2 to 3 months. Then there is a stage of remodeling, which continues long after clinical healing. It can continue up to 7 years. So first there is hematoma and inflammation, then primary callus response in 2 to 3 weeks. Then end condyle ossification occurs in that soft callus, leading to formation of hard callus, which takes place till 2 to 3 months. After that, remodeling occurs and continues after clinical healing, and it occurs up to 7 years. How do we define non-union? There are no strict definitions. There are some fractures that we know will go into non-union, so we do not wait for a particular amount of time to label it as a non-union. But for question's sake, more than 6 months we say it's a delayed union, and more than 9 months we say it's a non-union. But this is not true in clinical practice. Most common area for non-union is distal tibia. Diaphyseal fractures go into non-union more frequently than metaphyseal because of decreased blood supply. Metaphysis has abundant blood supply, and it can it can go into malunion, not non-union. So diaphyseal fractures are more commonly not uniting as compared to metaphyseal. Most commonly, non-union occurs because of inadequate immobilization. That is, the immobilization was not adequate, so there was gross mobility at fracture site, which didn't allow callus formation. So it went into non-union. On radiologics, on radiologic examination, what do we see? We see that the fracture line is still visible. The fracture has not united. For example, this was the fracture. This was a fresh fracture. Then when it goes into non-union, these ends will be smooth. This will not be sharp as they were here, and these ends will be sclerosed. So smooth sclerotic ends and fracture line visible, that is non-union on X-ray. There could be some callus formation. There could be some callus formation which is not bridging the fracture site. Callus formation could be there, but bridging callus is not there in non-union. So bridging of the fracture site did not occur. That's why the fracture did not unite. So there are different kinds of non-union. Because of different problems. One is hypertrophic, another is oligotrophic, and the third one is atrophic. Hypertrophic non-union means that there was exuberant callus formation, but the fracture did not unite. This occurs because of inadequate immobilization or stabilization. So body tried to immobilize it by forming callus. So the body formed a lot of callus. That is hypertrophic non-union. So what do we need to do in this? We need to do immobilization. We need to stabilize this fracture and it will go into union. On the other extreme, there is atrophic. No callus. Why did this occur? This is probably because of inadequate vascularity. So callus did not form. In this case, we need to do fixation plus bone grafting. Oligotrophic is somewhere in between. Some callus is formed. So the principles of non-union are that we need to give absolute stability. We have to do adequate immobilization. And we have to augment with bone graft. And we have to take care of the systemic factors. Maybe non-union occurred, maybe atrophic non-union occurred because the patient was malnourished. Maybe he was consuming tobacco. Maybe he was having too much alcohol. Maybe he was diabetic. All these factors need to be addressed before going into the final surgery. so that the recurrence of non-union does not occur. Then we come to upper limb trauma. If you people have any questions or any queries, you can type it in the live chat, or you can mention it in the comment box. I can refer to them later and answer accordingly. It will be better if you put your questions in the live chat so I can answer them right now. Let's go for upper limb trauma. So shoulder dislocates anteriorly most of the times. 90% of the times shoulder dislocation is anterior. Humeral head is slightly retroverted compared to femur head, which is anteverted. Humeral head is retroverted. Then we have rotator cuff muscles. They are dynamic stabilizers of the shoulder joint. Dynamic stabilizers. They are four muscles. Supraspinatus, which is the most commonly injured. Then we have infraspinatus, subscapularis, which is the forgotten tendon, and teres minor. So supraspinatus is the most commonly injured. Then we have rotator interval. It is the interval between the leading edge of supraspinatus and the superior edge of subscapularis. Coracohumeral ligament passes within it. Coracohumeral ligament passes within it. It is called rotator interval. Lift-off test is done for subscapularis. So now we are going to discuss about anterior dislocation, rather recurrent anterior dislocation. So there are two lesions, Bankart lesion and Hill-Sachs lesion, which are associated with recurrent anterior dislocation. So what are they? Suppose this is the glenoid and this is the humeral head. So when anterior dislocation occurs, there is traumatic detachment of some part of glenoid, that is in the anterior glenoid labrum. Traumatic detachment of anterior glenoid labrum. With anterior dislocation, this part is avulsed, that is called Bankart lesion. It can also be a bony Bankart lesion if some part of the bone is also avulsed from here. And when this dislocation occurs, the posterior, rather the posterior lateral aspect of the humeral head impinges on this part, on the glenoid rim. So there occurs a defect in the posterolateral aspect of humeral head, which is called a Hill-Sachs lesion. So both these can have recurrent anterior dislocation. Then there is posterior dislocation, which is less common. Most commonly it is subacromial type. Posterior dislocation most commonly it is subacromial type, and there is light bulb sign. These two things you need to remember. Questions have been asked multiple times about the most common posterior dislocation, that is subacromial type, and light bulb sign is seen. Recurrent dislocation is the most common complication of dislocation of shoulder, and recurrent dislocation is seen most commonly in shoulder joint. Recurrent dislocation is most commonly seen in shoulder joint. Recurrent patellar dislocation is the second most common dislocation. Most common recurrent dislocation is shoulder joint, and that too anterior dislocation. Coming to fractures, clavicle is the most commonly fractured bone in adults. It is the most commonly fractured bone in adults. And usually treatment is non-operative. Usual treatment is non-operative, and we give a sling or a figure of eight bandage. A sling or figure of eight bandage, and it heals on its own. Operative indications are few, which includes open fracture and when there is some deficit. In that case, we need to operate. Open fractures and those with deficit need to be operated. Another thing is when there is significant skin tenting, so that later it might lead to piercing of the skin and might lead to opening of the fracture, could lead to transformation into an open fracture. In those cases also we operate. So malunion is the most common complication of a clavicle fracture. Malunion is the most common complication. Then we have humerus fractures. There is something called Holstein-Lewis fracture. Holstein-Lewis fracture is a spiral fracture of distal third of humerus, and it is usually associated with the radial nerve palsy. Why spiral fracture? Suppose this is the humerus. I know my drawing is very pathetic, but that's all I can do. Suppose this is the humerus, so the fracture is spiral. So this sharp end impinges on the radial nerve and leads to radial nerve palsy. It is near to the radial groove, so it can lead to radial nerve palsy. This kind of a fracture, spiral fracture of a distal third with radial nerve palsy, is Holstein-Lewis fracture. Then we have some common nerve injuries associated with fractures. So if you look at this image, this is the axillary nerve, so it can be fractured in proximal humerus fractures or shoulder dislocations. This is the axillary nerve. Suppose there's a fracture here or there's a dislocation of the shoulder, axillary nerve can be damaged around the surgical neck of humerus. Then we have the radial nerve in the radial groove. It is very close to the bone in the radial groove, very close to the humerus. So radial nerve can be damaged in humerus shaft fractures and spiral fractures of distal third. We already discussed Holstein-Lewis fragment. Holstein-Lewis. Then we have ulnar nerve behind the medial epicondyle. Can be fractured in, it can be injured in supracondylar fractures and medial condyle fractures. Ulnar nerve is most commonly injured in medial condyle fractures. Medial condyle. So shaft fracture, as we already know, radial nerve injury can be there. Supracondylar fractures, so this is the mnemonic AMRU. A for anterior interosseous nerve, M for median, in that order: anterior interosseous followed by median followed by radial followed by ulnar. So this is the sequence of nerve injury in supracondylar humerus fractures seen in children. Medial condyle fracture, as we already discussed, and according to this image, medial condyle fracture or medial epicondyle fracture can have ulnar nerve palsy. Then Montague fracture can have posterior interosseous nerve palsy, which is a branch of radial nerve. Anterior interosseous is a branch of median nerve. Hip dislocation can have sciatic nerve palsy, as you all know, and knee dislocation can have common peroneal nerve palsy. Supracondylar humerus fractures. These are the most common elbow injuries in children 5 to 8 years, and extension type is the most common. More than 98% are extension type. More than 98% of supracondylar humerus fractures are extension type. Most common displacement is posteromedial. Most common displacement is posteromedial. Treatment is closed reduction plus cast or closed reduction and K-wire fixation. Closed reduction, percutaneous pinning. Either of the two can be done. Jones view is done to assess the reduction. Then we have something called fat pad sign. This is the fat pad. This is seen in occult fractures. When we are not able to uh, appreciate a fracture, we should look for the fat pad sign. It is seen in supracondylar humerus fractures. Then for assessment of reduction, we see Bowman's angle. Bowman's angle is between lateral physis and the long axis of humerus. Usually it is 75 to 90 degrees and it is increased in cubitus varus. So here is the Bowman's angle. What do? We draw on an AP view, we draw a line parallel to the longitudinal axis of the humerus shaft, and we draw a line along the lateral condylar physis. So this is a line along the lateral condylar physis. This is a line along the humerus shaft. So we have to take the lateral angle. We have to take this one, as I have written Bowman angle B for Bahar. Bahar wala angle lena hai, lateral wala. That is 75 to 90. We don't have to take this angle. We have to take Bahar wala angle, which is 75 to 90. And whenever there will be varus, so this will shift downwards and this angle will increase. So Bowman's angle increases in cubitus varus. Bowman's angle increases in cubitus varus. Malunion occurs in supracondylar humerus fractures. It leads to cubitus varus or gunstock deformity. So all we have to remember is it is the most common elbow injury in children 5 to 8 years of age. Most common is extension type, more than 98%. And most common displacement is posteromedial. Most common displacement is posteromedial. And we do Jones view for assessing reduction in drop, and we see Bowman's angle on AP view. Malunion causes gunstock deformity. So that's it with the upper limb fractures. Now we'll discuss about compartment syndrome. Compartment syndrome. Whenever there's a tight cast, in question mentions there was a tight cast, you should think of compartment syndrome. It involves most commonly the deep posterior compartment of the leg, followed by deep flexor compartment of the forearm. Forearm one is more common in children, the deep forearm compartment. In adults, usually it is the deep posterior compartment of the leg. And what is the clinical feature? Clinical feature is that pain is out of proportion to the injury. Patient is having too much pain, then we'll suspect compartment syndrome. First thing is patient is having too much pain, then we'll suspect compartment syndrome. Another thing is stretch pain. Stretch pain, that is on passive stretch the patient is having pain on passive stretch. Pulse is not a reliable indicator. Pulse is not a reliable indicator. Impending compartment syndrome. In impending compartment syndrome, fasciotomy is done. When do we do fasciotomy? When the compartment pressure is within 30 mm of diastolic pressure. So that is the delta P, that is the difference between the diastolic pressure and the compartment pressure is less than 30. So diastolic BP minus compartment pressure, if it is less than 30, then we have to do fasciotomy. So whenever there are tight casts, think of compartment. Deep posterior compartment of leg is most commonly affected. There is pain out of proportion to the injury. There is passive stretch pain. and pulse is not a reliable indicator. What do we do in fasciotomy? We incise the skin, the superficial fascia, fat, and the deep fascia, and we release the muscles. So, skin, superficial fascia, fat, and deep fascia are incised in fasciotomy. It's an emergency procedure. Volkmann's ischemic contracture. This most commonly involves the deep flexor compartment of the forearm, flexor digitorum profundus more commonly than flexor pollicis longus. Nerve involvement anterior interosseous is more common than median, more common than ulnar. Turnbuckle splint is used for the deformity correction. If more than 30-degree deformity is there, then we go for surgery. More than 30-degree deformity, we go for surgery. Max Page sliding operation is done in Volkmann ischemic contracture. Max Page sliding. Heterotopic ossification, also known as myositis ossificans. Hint is that there will be a history of massage. Patient had some trauma, following which he got massage done. Massage or passive exercise. If this is given, you should think of heterotopic ossification. Elbow is the most common region, followed by hip. Marker is ALP, as it is secreted from osteoblast and is a marker of bone activity. If there is unilateral calcification, it could be heterotopic ossification or myositis ossificans. If it is bilateral, it could be tumor calcinosis. We should get the workup done for some primary. There could be some primary which is unknown. Treatment is initially limiting the motion. Up to 3 weeks, we limit the motion. Then we start only active exercises. We don't give passive exercises. Someone else will not do the exercise, the patient himself will do it for himself. No one will stretch his hand or leg passively. That is done for up to 1 year. After that, surgical excision is done after 1 year. Low dose radiation and indomethacin can be used for prevention with doubtful efficacy. So there's a history of massage. Elbow is the most common site. ALP will be raised, and we do not have to operate till 1 year. We have to operate after 1 year, and we do only active exercises. No massage, no passive exercise. When we come to elbow dislocation, most commonly it is posterior. It is the most common joint to dislocate in children. Most common joint to dislocate in children is elbow. Most commonly it's posterior. Myositis ossificans is a late complication. Myositis ossificans occurs later in life after elbow dislocation. There is something called terrible triad of Hotchkiss. What is a terrible triad? It has 3 things. Triad obviously will have 3 things. So there's first is elbow dislocation, then there is radial head fracture, and there is coronoid fracture. So if these 3 things are fractured, primary as well as secondary stabilizers are disrupted. So recurrent instability is a rule in this case. That's why it is called terrible triad. That's why it is called terrible triad. It needs to be operated. Otherwise, recurrent instability is always there. That's why it is called terrible triad of Hotchkiss. Elbow dislocation, radial head fracture, and coronoid fracture. Then we come to Monteggia fracture. always used to have confusion between Montegia and Galeazzi. It's very difficult to remember for me. So when I was doing my MBBS, so that's the mnemonic I made. M for Montegia, M for medial bone. Medial bone out of radius and ulna, that is ulna. So it is a fracture of ulna. It's a fracture of medial bone, that is ulna. Then U for ulna and U for upper. So upper end of ulna fracture with dislocation of radial head. So upper third ulna fracture, with radial head dislocation. That is Montegia fracture. Anterior dislocation of the radial head is the most common, that is Bardo type 1. Bardo classification is used for Montegia fractures. Bardo type 1 is anterior dislocation of radial head. It is the most common, which is also called extension type. Posterior interosseous nerve palsy can occur in Montegia fractures. So upper third ulnar fracture with radial head dislocation, and anterior dislocation of radial head is most common, that is type 1 Bardo, which is called extension type. Then we come to Galeazzi fracture. It is the opposite, that was proximal, so this is distal. That was ulna, so this is radius. Distal third radius with distal radioulnar joint disruption, drudge disruption. So that's the difference between Montegia and Galeazzi fracture. Now we come to pulled elbow or nursemaid's elbow. It is usually seen in 1 to 4 years of age. Forearm is pronated. Actually, there is subluxation of the annular ligament, which can be reduced by forceful supination. So here this is normal annular ligament. When the elbow gets pulled, it leads to subluxation of the annular ligament superiorly. So the child comes with a flexed elbow and pronated forearm and wrist and complains of pain. Forced supination leads to reduction of the ligament and relief of pain. तो कुछ नहीं करना, आपको बस बच्चे से हाथ मिलाना है, अपने आप रिड्यूस हो जाएगा. So here's a question. A 4-year-old child was playing with her maid where she rotated her by holding her from arms. Immediately afterwards, the child started crying. On examination, the arm was pronated. What is the likely diagnosis? So one thing is holding from arms, so pulling force is there. The child started crying immediately, so 4-year-old child, and the arm is pronated. So these point to pulled elbow. Fractured olecranon is a kind of an avulsion fracture. The triceps attachment is there on olecranon. And treatment is tension band wiring. We do tension band wiring in olecranon fractures. Same with patella fractures. Patella fractures also we do tension band wiring. Essex Lopresti fracture involves radial head and interosseous membrane. Radial head as well as the interosseous membrane. So in forearm fractures, what is the cast position? In what position should we put the cast? So it is a simple mnemonic. P is not for P. That is, the proximal forearm fractures are immobilized in supination, not in pronation. So P is not for P. Proximal fractures in supination, distal fractures in pronation, and mid shaft in mid prone. So why is this? Proximal forearm fractures to neutralize the pull of supinator muscle and the biceps brachii, we immobilize them in supination so that they get reduced and the pull of the supinator and the biceps does not occur. That's why proximal forearm fractures are immobilized in supination. But you can remember this much: P is not for P. Now we come to distal and radius fractures. First is Colles fracture. Colles fracture is a low energy fracture. It is seen in elderly. So basically there is distal radius extra-articular fracture at the corticocancellous junction. Fracture at the corticocancellous junction, it is extra-articular. For example, this is the radius. So here is the fracture. It is extra-articular at the corticocancellous junction. So what all angulation and displacement occur in this? There is a dorsal angulation, this is a dorsal combination, and a dorsal displacement along with radial shortening. This fracture occurs due to fall on outstretched hand when the wrist is in dorsiflexion. Since the wrist is in dorsiflexion, it fell like this. The position of the hand was like this. So it went into dorsal angulation, dorsal combination, and dorsal displacement along with shortening. So there was tension on the volar aspect. There was tension on the volar aspect, therefore fracture extended dorsally. Treatment is closed reduction and casting. Handshake cast is given in Colles fracture. So if there is dorsiflexed hand, there will be Colles fracture, and if there is palmar flexed hand, then there will be Smith fracture, that is reverse of Colles. It's also called reverse Colles fracture. So what exactly is a hand shaking cast? Hand shaking cast, we give ulnar deviation and volar flexion. Complications of Colles fracture. Finger stiffness is the most common complication. Then there is malunion, that is dinner fork deformity occurs. Fernandez osteotomy we do for the correction of dinner fork deformity. Then we know Smith fracture, it is reverse of Colles and it leads to garden spade deformity, the opposite of dinner fork. There are some other distal radius fractures. So Colles and Smith we already know these are low energy fractures. Then we have something called die punch fracture. It is an impaction of the lunate into the lunate fossa. Impaction of lunate into the lunate fossa. It's a high energy fracture. Just like a die punch, the punch has created a hole inside the die button. The part material has been punched out. So similarly, the lunate has punched a hole into the distal radius, and the impaction of this lunate fossa, this is the lunate fossa, this has impacted inside, so it is a die punch fracture. Then we have Barton's fracture. It is a fracture dislocation of the radiocarpal joint with intra-articular extension involving either the dorsal or the volar limb. So fracture dislocation of the radiocarpal joint. For example, this is a volar Barton fracture. So this is the volar lip, this got fractured and the whole of the carpus came along with the volar lip. So there is joint subluxation or dislocation. Here the space is increased. So this is a volar Barton. Similarly, with the dorsal chip and dorsal subluxation, there is a dorsal Barton fracture. These need to be operated. Same as die punch fracture also needs to be operated. Colles and Smith, they can be managed non-operatively. Then there is Schoffer's fracture, which is radial styloid fracture, as you already know. There is, let's move on to the next topic, that is Sudeck's osteodystrophy, also known as complex regional pain syndrome. What is complex regional pain syndrome? It is an idiopathic condition caused by aberrant inflammatory response. The inflammatory response is not correct, it's aberrant. Aberrant inflammatory response has led to sustained sympathetic activity in a perpetual reflex arc. So it is an idiopathic condition, poorly understood. We don't exactly know the reasons. The patient presents with extremity pain which is out of proportion to the physical examination findings. We don't know the cause of such pain. The patient has pain out of proportion to the findings, and diagnosis is usually clinical. We have Budapest diagnostic criteria for the same, and it is a diagnosis of exclusion. It is a diagnosis of exclusion. First thing is that the patient has pain out of proportion to physical exam. Then the second thing is we have some symptoms from out of these: motor, sensory, vasomotor, and pseudomotor. So at least 3 symptoms out of these 4 should be present. That is Budapest criteria. And signs also, 3 signs out of these 4 should be present, and there should be no other explanation for the cause of pain and other symptoms. So it is a diagnosis of exclusion. Sudeck's osteodystrophy or complex regional pain syndrome, it's a diagnosis of exclusion. There is sympathetic overactivity which leads to all the changes. So there are 2 types of CRPS. This is old classification, but it's still asked. Type 1, where we cannot find any evidence of nerve injury. We could not find any evidence of nerve injury. That is type 1. It develops after trauma like Colles fracture. Second is peripheral nerve injury is present. Median is more common than sciatic. Treatment in both these is physiotherapy, but the results are poor. There is patchy osteopenia seen on radiographs and skin changes occur. Then we have Langford stages: acute, subacute, and chronic disease. Langford stages, that's how we do staging. Vitamin C has some role in prophylaxis for CRPS. So complex regional pain syndrome, it is also known as Sudeck's osteodystrophy. It is idiopathic condition and occurs due to aberrant inflammatory response with sustained sympathetic activity. There is pain out of proportion, and diagnosis is usually clinical, and it is a diagnosis of exclusion. Then we come to carpal bones. Among the carpal bones, scaphoid fractures are the most common. Among the carpal bones, scaphoid is the most common. Middle third fractures, that is the waist fracture of the scaphoid, is more common than the distal pole. Distal pole is usually fractured in children. Sign is there is tenderness in the anatomic snuff box. This is a classic sign for scaphoid fracture. And then we can also do Watson test, that is the scaphoid shift test. This is done for the integrity of scapholunate ligament. If the scapholunate ligament is injured, scaphoid shift test is positive. oblique views are important for diagnosis is it's usually missed on initial x-rays. So we should go for clinical diagnosis. If there is tenderness in an admixed stuff box, we should immobilize and repeat x-rays after 14 days, or we can go for MRI, because sometimes it's an occult fracture. MRI can be done for occult fractures, as we already know. Treatment is glass holding cast or headless screw for surgery. Complications: non-union is more common than avian, and it is more in proximal fractures because it has a retrograde blood supply. That is, the blood comes from distal to proximal. So जितना proximal fracture होगा, avian होने का chance उतना ज़्यादा होगा because of retrograde blood supply. Then we talk about scapholunate dislocation or dissociation. We see scapholunate gap on a clenched fist view of the wrist, and if it is more than 3 mm, it means there is scapholunate dissociation. It is also called Terry Thomas sign or David Letterman sign. So this is the gap. So this person is named Terry Thomas. He was a British anchor. So this gap is similar to the gap between his two teeth, the diastema, and that's why it is called Terry Thomas sign. He's David Letterman. As usual, Americans could not stay with a British name, so they came up with their own. This guy is American actor, so they came up with their own sign. So David Letterman sign is the same as Terry Thomas sign. There is no difference. Basically, the scapholunate gap is more than 3 mm. It is seen in scapholunate dissociation. There's another thing called cortical ring sign. Here is the cortical ring sign. Here you can appreciate the ring in the scaphoid. That is because of the end-on view. The profile of the scaphoid has changed. It is more flexed, and that's because of scapholunate dissociation. This is Terry Thomas or David Letterman sign, as we have already discussed. Then we come to lunate dislocation. In lunate dislocation, this is the normal lateral view. This is the lunate inside the lunate fossa. This is lunate dislocation. So here's the lunate. This is the lunate. It looks like a spilled teacup. Spilled teapot sign is seen on lateral view. It looks like the pot has spilled. And on AP view, we see the pi sign. This is the normal AP view. This is the lunate. This is the lunate in normal AP view, and this is the lunate in lunate dislocation. So here we see pi sign, just like a pie of a pizza. It's triangular because of the dislocation. So two signs: spilled teapot sign on the lateral view and pi sign on the AP view is seen in lunate dislocation. Perilunate dislocation. What is the difference between a lunate dislocation and a perilunate? In a lunate dislocation, the lunate dislocates. In a perilunate dislocation, the lunate stays in its place and the carpal bones dislocate. So this is a perilunate dislocation. You can see on your right, this is the perilunate dislocation. The lunate is in its place and the carpus has dislocated. Here in lunate dislocation, the lunate has dislocated, rest of the carpals are in line, and this is the normal lateral view. Then on x-rays we have glula lines. These are congruent arcs of carpal bones in normal wrist X-rays. There are three lines. This is the first line at the proximal end of the proximal row of carpals. Then the second line is the distal end of the proximal row of carpals, and the third line is at the proximal end of the distal row of carpals. These three lines form an arc. If there is any fracture or dislocation, these arcs are disrupted. Gilula lines. Then we come to fractures of the hand. Bennett fracture. Bennett fracture is fracture dislocation of first metacarpal base. It is intra-articular. And then there is Rolando fracture, which is comminuted fracture of the base of first metacarpal. So Bennett fracture is fracture dislocation. Rolando fracture is comminuted fracture of the base of first metacarpal. Both are intra-articular. It's just that Bennett has dislocation, Rolando doesn't have. I'm sorry, I said Ronaldo. Of course, Ronaldo is the greatest footballer. He can't be dislocated or displaced. So no dislocation in Rolando fracture, but Bennett fracture, it's a fracture dislocation. Mallet finger. Mallet finger is avulsion of the insertion of extensor tendon from distal phalanx. Avulsion of the insertion of extensor tendon from distal phalanx. Jersey finger is the opposite. It is the rupture of the flexor tendon, which is the tendon that bends the finger down. This name comes from football athletes who grip the jersey in an opposing player who is trying to get away. So the flexor tendon is injured in jersey finger and the extensor tendon is injured in mallet finger. There's something called Kaplan dislocation, that is dislocation of the metacarpophalangeal joint. It is classically seen in index finger. Then we discuss about carpal ossification. Ossification of the carpal bones occurs precisely in a predictable manner. We have to start from capitate and move towards pisiform. So capitate, hamate, triquetrum, lunate, scaphoid, trapezius, trapezoid, pisiform. So here is the capitate. We start from the capitate and move clockwise. We start from capitate and move clockwise. So after capitate, hamate. After hamate, we leave the pisiform out. After hamate, there is triquetrum, then there is lunate, then there is scaphoid, then there is trapezoid and trapezium, and then at last there is pisiform. So this is the circle, and at last there is pisiform. So capitate ossifies at 1 to 3 months, followed by hamate 2 to 4 months. These two ossify first. After that, 2 to 3 years. Remember, 2 to 3 years, or maybe 2 to 4 years we can do. 2 to 4 years, there is triquetrum and lunate. Just going clockwise. Capitate, hamate, then triquetrum and lunate at 2 to 4 years. Then we have scaphoid, trapezium and trapezoid at 4 to 6 years. 2 years gap. Previously it was 2 to 4, now we have 4 to 6. So scaphoid, trapezium, trapezoid, all three at 4 to 6 years. And at last there is pisiform, that is 8 to 12 years. So that's easy. We start from capitate. And move clockwise, and then we take pisiform at last. So 2 to 4 months, 2 to 4 years, 4 to 6 years, and 8 to 12 years. Simple. Start with ulnar side bones. and move clockwise, except pisiform. So that was about carpal ossification. This can be asked in question. Then we come to spine injuries. Dislocations are common in cervical spine. Dislocations are common in cervical spine. What is vertebroplasty? Vertebroplasty is a percutaneous injection of bone cement, that is PMMA, polymethyl methacrylate, into the vertebral body. So there is a osteoporotic vertebra. For example, this is the vertebra has osteoporotic collapse. For example, this is the collapsed vertebra. So to prevent further collapse of the osteoporotic vertebra, we percutaneously inject bone cement, that is polymethyl methacrylate, into it. So this procedure is called vertebroplasty. It is used for osteolytic vertebral metastasis, multiple myeloma, and osteoporotic collapse. It is contraindicated in case of infections. It is contraindicated in infections. Only done in osteoporotic and multiple myeloma and vertebral mets collapse, not in infections. Should not be done in infections. Vertebroplasty just prevents further collapse, whereas kyphoplasty is correction of the collapse by using high pressure, but we don't prefer it nowadays. Kyphoplasty leads to correction of the collapse. It's not usually done nowadays. We have central cord syndrome, that is motor weakness with arm weakness out of proportion to the leg weakness. It is the most common incomplete spinal cord injury syndrome. This is the most common incomplete syndrome. It has a relatively good prognosis. Anterior cord syndrome has worse prognosis. So incomplete spinal cord injury with best prognosis is Brown-Sequard, which is the hemisection. Hemisection has the best prognosis. Then we come to fractures of the cervical spine. Jefferson fracture, it is the burst fracture of ring of Atlas, that is C1 fracture, vertebral compression type of fracture. It's called Jefferson fracture. It is a burst of C1, that is the Atlas. Jefferson. Hangman fracture. Hangman fracture is traumatic spondylolisthesis of axis, also known as Hangman fracture, is a traumatic fracture of bilateral pars. So the axis, the second vertebra, bilateral pars interarticularis is fractured. That is called a Hangman fracture. Traumatic spondylolisthesis of axis. Deficit usually does not occur in these two fractures because there is a wide canal. The cervical canal is wide, so neural deficit is usually not there. Atlanto-occipital joint is for yes movement and atlantoaxial joint is for no movement. Yes movement, atlanto-occipital; no movement, atlantoaxial. Odontoid fracture, that is the dense fracture, Anderson-D'Alonso classification is used, and type 2 fracture requires screw fixation. Type 2 requires screw fixation. So here is odontoid fracture classification. Type 1 is fracture of the upper part of the odontoid. This is the odontoid process and the upper part gets fractured. It's rare and it is potentially unstable. Type 2 is fracture of the base. This is the base fracture. It is unstable and there is a high risk of non-union. So this needs screw fixation. This needs screw fixation. Type 3 is through the odontoid and into the lateral masses of C2. It has the best prognosis for healing. It does not require surgery. That's the best prognosis for healing. Type 2 most commonly requires screw fixation. Chance fracture is the flexion distraction injury leads to facet dislocation. Chance fractures are traumatic fractures of the thoracic and lumbar spine that occur by flexion distraction injury and are associated with high rates of mechanical instability and gastrointestinal injuries. So these are flexion distraction injuries, like two forces are acting. First is flexion, another is distraction. So they are mechanically unstable fractures. If you see the spine, you will see, for example, if this is your spine, chance fracture will be something like this. It will pass to the posterior elements. It will be a through and through fracture. The Here will be distraction forces. Here there is flexions. This is flexion, and the posterior column is failing in distraction. So flexion distraction injury is chance fracture. So there are high rates of mechanical instability and high chances of gastrointestinal injuries. Then Clay-Shawler fracture is the avulsion fracture of spinous process of C7 more than T1. C7 is more common. Clay-Shawler's fracture is a fracture of spinous process of C7 and T1. Scivora is that X-rays are normal, but there is neural deficit. It is seen in pediatric age group, that is spinal cord injury without obvious radiological abnormality. It is seen in pediatric age group due to lax ligaments leading to cord traction without any bony injury. It leads to cord traction without bony injury. Cervical spine is most commonly affected. C-spine is most commonly affected. In axial loading injuries, dorsolumbar junction is the most commonly affected. Why? Because there is a change of curvature. Dorsal spine has a kyphotic curvature, lumbar has a lordotic, so it's like this. So at this point where the curvature is changing, if axial load will be applied on this, this is where fracture can occur. So dorsolumbar junction can have axial loading injuries. Spina bifida occulta is the most common type of spina bifida. Most common site for spina bifida is S1 more than L5. Then we know Dennis gave the three-column theory for spinal instability. Block vertebrae are seen in Klippel-Feil syndrome. Klippel-Feil syndrome has block vertebrae in the C-spine. So if a patient comes with spine injury to the trauma center, what are the sequence to be followed? How do we manage the patient? So first of all, we should stabilize the cervical spine. Stabilize the cervical spine as the first step. Then we look for usual trauma, ABC, airway, breathing and circulation. Then we look for disability or deficit, and then we will proceed accordingly. We do ASIA scoring and reflexes are checked once the spinal shock is over. So initially after trauma, the patient might be in spinal shock. How do we check that? Uh, if the patient has spinal shock, patient will be areflexic. There will be depolarization of the entire spinal cord. So how to differentiate it from deficit? The one thing we can do is we can check for bulbocavernous reflex. If this reflex is absent, the patient is still in spinal shock. Once this reflex returns, after that we check for the deficit and the reflexes. So it's very important to check for bulbocavernous reflex. Spinal shock usually subsides within 24 to 72 hours. So there is Asia scoring. Asia, नाम से एशिया बट ये अमेरिकन है. American Spinal Cord Injury Association Impairment Scale. So that is Asia Impairment Scale, AIS, Asia Impairment Scale. So in this we check all the dermatomes for light touch and pinprick, sensory light touch and pinprick in all dermatomes, and we score it from 0, 1, 2. The caudal-most dermatome where both are present is the sensory level. Both light touch and pinprick should be present, and the caudal-most dermatome where this is present will be called the sensory level. All the sensory scores are added, so we take 28 dermatomes. All scores are added for, so to each there will be 56 on right side, 56 on left side. Then motor function is checked in 10 paired myotomes. This is not important. All you need to know is that, let's skip this part, this is not important for you, let's forget this. So uh, the lowest key muscle function, which has at least 3 power, is the motor level. So basically you need to remember this thing, this last thing, Asia A to Asia E. Asia A is complete deficit and Asia E is no deficit. This is all you need to remember out of this scoring. You can forget about rest of it. So this is the Asia chart for the scoring. So what are the surgical indications in spine? If there's a worsening deficit, for example, or there is a unstable fracture pattern, there may be skeletal disruption or bladder bowel involvement. All these cases need surgery. They need to be fixed surgically. Worsening deficit, unstable fracture, skeletal disruption, bladder bowel involvement. What is a Trendelenburg test? Trendelenburg test is done to assess the integrity of the abductor mechanism. It can be positive if either the fulcrum, that is the femur head, or the liver arm, that is the neck length, or the power, that is muscle or nerve, is affected. So basically paralysis of the abductors could lead to a Trendelenburg positive test. So we are assessing the abductor mechanism in Trendelenburg test. So power, the paralysis of abductors can be there in superior gluteal nerve palsy, which supplies the gluteus medius, the minimus and tensor fasciae lata, and it can occur in polio and iliotibial tract palsy. Decreased lever arm, as in fracture of the neck of femur, and absence of stable fulcrum such as Perthes, AVN, and late stages of TB hip, that is stage 3 onwards. When there is significant arthritis, then absence of stable fulcrum will be there. Thomas test is done to test for flexion deformity of the hip. Thomas test is for flexion deformity of the hip. So Shenton's line, it is a radiological parameter seen on the AP X-ray. We draw a continuous line from the medial cortex and the calcar of the femur along the head, neck and head of the femur, and then along the superior pubic ramus, the inferior border of superior pubic ramus. So this is breached in, for example, there is a neck femur fracture. It's a fracture here, it can be breached. If there's a head femur fracture, again this can be breached. If there's a superior pubic ramus fracture, then also it can be breached. And for example, if the hip is dislocated, then also this will be breached. So Shenton line to look for the integrity of the hip and pelvis. So I think that's it for today. We will continue some other day. If you have any questions, any queries, please let me know in the chat section. Have a nice weekend and revise all that I have taught you. Thank you everyone. Hope this session was useful for you.